Hello, 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 my friends. Happy Halloween. Oh, we are now in the midst of a glorious fall season. The harvest is complete. Everything is beginning to rest again. And we, with our icy, hopefully, we are resting too. All righty, now I got to fix something here. So, my name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, October 31st, and it is time for another IC support group meeting. Hello, Lisa. Nice to see you. We are simulcasting live on YouTube and Facebook. I realize that some people are going to be out trick-or-treating and doing stuff. Oh, gosh, I forgot to. Oh, I got to turn on I got a dragon out in front. Got to turn on my dragon. So, anyway, my purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody to minimize you, to diminish you, to tell you that you're damaged goods, to tell you that this is all your fault, to tell you that there are no therapies. There is hope, my friends. There is tremendous hope. We have come so far in our understanding of IC. Patients, we are no longer thinking of IC as an incurable bladder disease, and we haven't been that way. Gosh, you know what? Since 2008, we think of IC as a pelvic pain syndrome. Why? Because structures outside of the bladder are often involved. So today, we have a much better track record of finding the right treatments for the right patient, right? Not everybody can be taking Elmeron or bladder therapies. For many patients, bladder therapies don't work. They just don't work. Hello, Caroline. Nice to see you. Very, very nice to see you. Let me make sure I got this all set up correctly. Hello, Facebook. Now, I realize this is a challenging day. This is a big day for some families. So, Melissa says, "Thank you for telling me to get a doctor. I feel so much better with my new doctor. He has this potty that measures the amount and frequency. He gave me so much more hope." Yeah, baby, woohoo! That's what we like to hear. That's what we like to hear. So when I normally do these meetings, I start out with a 30-minute, a mini educational thing, lecture, whatever you want to call it. And then I usually go ahead and take questions. All right, we're already getting an error on Facebook. Current frame rate is too low. Please set frame rate 15 to 60. I don't know how to do that. How do I do that? Let's see. I don't know how to do that. Hold on. Well, yeah. All right, Facebook, my friends, let's just see what happens. We've had issues with Facebook before. If it works today, great. If it doesn't work today, we will be doing it again for sure. I just want to. Let's see if that makes a difference. That better? Facebook, Melissa, Lisa, Caroline, what do you think? Is that okay? Testing 1, 2, 3. Testing 1, 2, 3. Yeah, the tricks are going to get me today. So much for trick or treating. I would. Don't you wish you could just go back to your childhood when we could all trick or treat? It was glorious. My childhood Halloweens were so wonderful. They were so incredibly wonderful. Tyler says, "My doctor saying I need to have a urodynamics test done. Is there any point in doing this test? I heard it would be painful." Tyler, listen, the urodynamics test is not particularly painful. Basically, all they're doing is testing the nerve function in your urinary tract. So what they will do is insert a cystoscope or another device, catheter, into your bladder. Then they will slowly fill it with fluid, and then they will be asking you questions like, when do you first feel the urge to urinate? When do you first feel like you're starting to feel discomfort? And so all they're doing is testing kind of your waking bladder function, for lack of a better term. they will so again, it's gonna be, when do you first feel the need to urinate? And then the second question is gonna be, tell us when you first feel a little bit of discomfort. And then sometimes they push just a little bit past that, but you have the right to say, "Stop, that hurts." A urodynamics test is not considered critical to a diagnosis of IC. There have been a lot of debates about it. It's at this point in time considered fairly irrelevant unless they suspect another sort of nerve dysfunction happening. I can give you some journal articles that talk about it, but you can see in the American AUA guidelines for IC that it's not considered a critical test for the diagnosis of IC. Oh, Jessica's having her 11th wedding anniversary. Awesome. Hello, Melissa. Hello, Ann. So what test is good to see if other issues are going on with your bladder to rule out IC? Well, it really, honestly, what we're going to be looking at is UTI, bladder cancer, chemo-induced cystitis, bladder stones, or any other kind of injury or trauma to your bladder. I have a very interesting story that I've shared multiple times with a internal medicine doctor that I met, retired internal medicine doctor. I met her at our local pub on trivia night. It was hysterical. And so after we were done, it's like, what do you do? I said, hey, I work with IC. And she goes, hey, I've got an incredible story to tell you. And it's like, all right, give it to me. I love good bladder stories and good IC stories. And she said, well, so she was a pretty strong athlete, right, too. So she was, even though she was retired, she was over 60, she was still enjoying being an athlete. Then suddenly out of the blue, she started getting urinary symptoms, kind of frequency urgency, especially when she was working out. So she thought she had infection. So she goes to the doctor, they rule out infection. The doctor's like, I don't know. And it continues to get worse. And then she gets maybe it's all in your head, maybe, you're imagining it, maybe it's not that big of a deal. The classic thing that every IC patient has heard at one point in time, even doctors with IC have gotten. And it continued to get worse and worse. And so she got to the point where she couldn't work out. I mean, it was really that bad. And then one day she felt a strong need to push. So she pushed, and out popped either a green or a blue piece of plastic, a stitch. It was a polystyrene stitch. She's like looking at the toilet going, what the hell is that? Came right out of her bladder. Baffled. And she was so shocked by it, she actually flushed it away. She didn't even take a picture of it. So she calls the doctor, and the doctor goes, hey, you're not going to believe what happened, but I just peed out a stitch. And the doctor's like, yeah, right. And she felt better after she peed out the stitch. She did for a couple of weeks. And then it got worse and worse and worse again. And then it got really, really, really severe to the point that she could barely walk. Her pain was so bad. So she goes back to the doctor, and the doctor goes, all right, we better take a look. So they did a laparoscopy. You know what they found? You want to talk about the stuff of Halloween nightmares? She had her belly full of stitches moving all over her body, all throughout her pelvis. They're migrating throughout her pelvis. They were stunned. Woke her up. Well, they took out as many as they could, right? As many as they could find. The problem with these stitches is that these are stitches that are never meant to be used internally. They're only meant to be used externally. When she had a baby, she had afterwards a little tummy tuck because I guess the baby was really big and she felt comfortable having a little tummy tuck. So she let a med student do the tummy tuck. Med student used the wrong stitches. And these stitches are known for migrating through tissue, just like mesh is known for migrating through tissue. And that is exactly why she had her pelvic pain and her pelvic symptoms. It's crazy. And again, imagine you got something fundamentally dysfunctional in your pelvis, and somebody has the audacity to say it's all in your head. And when they opened her up, they found all, and she's not the first patient I've worked with who's had that happen. I had another patient that I worked with too, who had some sort of pelvic surgery. And immediately after the surgery, she had really all the symptoms of IC. She was diagnosed with IC. But when they went in and looked, what they found was a stitch had perforated her bladder wall. And when they pulled out the stitch, symptoms went away. Her symptoms went away. So, we're going to be looking at multiple concepts here. We're going to look at traumatic injury. We're going to look at other related conditions. We want to know if you've got fibroid tumors, endometriosis, if you're a female. We want to know what the health of your pelvic floor muscles are, because those are a really common issue for many of us. There are a myriad of other conditions that can cause this. It's really remarkably stunning. So you guys give me 1 sec. Somebody's calling for me. I'll be right back. All right, we are good. We are good, 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 good. All righty. So, again, a diagnosis of interstitial cystitis is a diagnosis of exclusion. We got to rule out other stuff. And if they suspect that you have something fundamentally wrong with the way your bladder operates, then they might want to do a urodynamics to kind of test your muscle function. Hold on, something's falling. Stay. I'm wearing my Lady of Shalott costume just for fun. Mandy said, I am being told the pressure I feel in my bowel area after peeing is not related. And now when I have a bowel movement, my bladder aches. Hello, Mandy. Mandy, pelvic floor. Pelvic floor. That's the connection between the bladder and the bowel in that circumstance. So, especially if you're straining, we have to look at the pelvic floor. Ruth says, when I'm on my period, why when I'm on my period does it ease my pain and pressure? The moment my week is over, it starts all over again. Concept number one is distraction, that there might be, your brain might be focusing more on menstrual cramping as compared to bladder pain. But it's far more likely that you are just sensitive to some of those hormone swings. For some people, I see flares when they're high in estrogen. For others, I see flares when they're high in progesterone. And that's kind of one of the really interesting mysteries that we're facing with IC is there's so many variations in how patients are presenting. It's just not everybody's the same, guys. Not everybody has a bladder disease. Hello, not everybody has a bladder disease. Some of you have something else going on, but there can be some hormone fluctuations too. All righty. So, listen, I have some news here. Hold on a sec. Yes, I spent my afternoon yesterday. Hi, Lisa. Going through some of the latest research because I'm prepping my fall magazine to go to print, and I wanted to do our research survey for our next issue of the IC Optimist. And what did I find? Finally, we know why Lyris never got to market. So Lyris, for those of you who don't know what Lyris is, imagine a small hollow piece of spaghetti filled with medicine. Now, the challenge with treating any sort of bladder issue is that if you put medicine in the bladder, you pee it out within a couple of hours. It's very hard to give the bladder a consistent flow of medication, right? So researchers at MIT created a new medical device called Lyris. It is like a soft, hollow piece of spaghetti filled with medicine. What they do is they put it in your bladder where it kind of wraps itself up so it can't come back out. And it can stay in there for a couple of weeks and to deliver medicine. So it's the brand name is known as Lyris. We also call it the lidocaine pretzel. So Lyris was really exciting when it first came out because, I mean, number one, imagine what it's going to do for the treatment of UTI. Imagine what it could do for the treatment of bladder cancer, right? I mean, to be able to deliver medicine into the bladder is amazing. Their original intention was to treat pain. So they used lidocaine. And the original study up in Canada was shockingly good. The original study up in Canada, which was, I don't know, 12, 15 patients, something like that, found that patients responded beautifully to this lidocaine therapy. And more importantly, what got everybody excited is patients who have Hunner's lesions, the lesions healed completely. The quote was a complete and total resolution of the lesion. That's what they used in the very first research study when they presented that data. So everybody got really, really, really excited about Liris as a way of treating Hunner's lesions. And so in that study, what they found was lesions responded beautifully and healed with lesion therapy, with Liris therapy. And then as this was sent to various clinics around the country for their own research purposes, more and more and more doctors also showed that lesions were getting smaller, they were getting fewer, and quite a few patients had lesions that were healing. So is it remarkable, because this would have been the first treatment in history to heal Hunner's lesions completely. Hunner's lesions affect 5 to 10% of IC patients. It's considered its own unique disease. It's not, there's been a very strong movement to separate it from people without lesions, because lesions present very differently. And when we biopsy them, they're extremely different than the rest of us. So Hunner's lesions are now considered Hunner's lesion disease, and it's pretty a separate group. And again, it represents the most severe IC patients, or patients with bladder symptoms. So anyway, excitement built, and patients who had it were excited. I talked with many of them. They called me. They went, "Oh my God, Jill, my lesion's healed." They were ecstatic, absolutely ecstatic. So the company that really had it, which was Terrace, did a couple of small studies trying to get it ready to go through the FDA pipeline. And then Allergan bought it. Allergan is known for Botox. They're the ones who are reaping billions of dollars from Botox therapy, as well as many others. I actually interviewed at Allergan when I got my pharmacology degree. That's a whole nother story. Whole nother story. They were doing primate research, and anyway, it's awful. So anyway, excitement built. Allergan buys it. Allergan has a deep pool of money. They go, all right, let's see if we can reproduce the data. So they started doing their own studies. Now, the challenge with what they were doing is they didn't want patients who had already had it to do the study. And so it was very hard for them to get enough patients in their study. The doctors were kind of laughing about their criteria for their studies, because it was almost impossible. Like, we expect this patient to have severe pain and severe Hunner's lesions, but to never, ever be using pain medicine, and to agree to have a hydrodistension without anesthesia, right? I mean, there were huge issues with the way they had designed those studies. But anyway, things slowly worked through the pipeline, and guess what? It failed. It failed. That in a multi-center study, in a study specifically designed to treat Hunner's lesions, Liris failed. And that is indeed why it was shelved. And they finally published the data. And I have the data. Hold on a sec. Where is it? Where did I put it? Safety, tolerability, and efficacy of Liris 400 milligrams in patients with or without Hunner's lesions. And it was published by Rob Evans, Robert Moldwin, Ken Peters. So come on, you got the top 3 IC researchers in the nation right there. And 2 phase 2 studies. Well, let's see. Hold on. So about 200 patients received it respectively, and there was no statistical significant difference in changes in their bladders and in their symptoms. There was no clear trend for a reduction in the number of Hunner's lesions in Liris versus placebo. The studies did not demonstrate a treatment effect for Liris 400 milligrams when compared with placebo, either in patients with Hunner's lesions or those without lesions. So it's baffling. I mean, it's baffling because I know that we have had some of these patients in these meetings, and um, they were desperate to get it again. They felt so good when they used the Lyris device, and their lesions did respond. But what this much larger, more rigorous study found is that it didn't. There was not a consistent benefit over time. That, got to be real here. It's all about money, honey, and the company is not going to be putting a lot of money into a therapy that is marginally effective. my, my window is falling. Get back up there. All right. On the other hand, what we do have is a study that showed that cyclosporine, in fact, was remarkably successful. There are multiple studies with Hunter's lesions that came out this fall. So, evidence for early cyclosporine treatment for Hunter's lesion interstitial cystitis with cyclosporine. Okay, so let's see here. SciA responders were defined as those with moderately or marked improved scores, a total of 51 patients with Hunter's lesion. IC were treated with cyclosporine. Their mean follow-up was 3 years. 76% were female. Before treatment, an average of 8 therapies were tried, and patients reported an average of 8 out of 10 bladder pain. Daytime frequency is 11 to 20 times a day. Nocturia was 7 times per night. And what this study found was that 84% of those patients had a significant improvement in their symptoms while using cyclosporine. And that's not surprising because, we do have some evidence that Hunter's lesions may involve a very strong inflammatory process happening. There's a lot of inflammation happening in the bladder. So that kind of makes a little bit more sense. Study on hypnosis, which makes sense because we now know patients who have chronic overlapping pain conditions, their brains are stuck in fight or flight. They're living with heightened muscle tension, heightened heart rate, heightened blood pressure, and a more sensitive central nervous system. So we certainly would now understand why something like hypnosis would be helpful, because it would break that patient out of fight or flight, right? It would calm that central nervous system. So that's reasonable. It's another study for cyclosporine, again, found to be helpful. It's a urobiome study where they're really trying to understand all the good things that live in the urinary tract as compared to the bad things. Risk of autoimmune diseases with IC. Anyway, so that was the big take home for me, was the fact that now we know why Lyris was basically pulled from the research studies. And it's a very, very disappointing. I'm going to have to change our website, remove it as a therapeutic option. So, but it's going to be amazing for what it does for cancer therapy and for UTI therapy. So that just sucks eggs, right? It just sucks. Angela says, oh, Mandy, thank you so much for the 50 stars. Mandy says, they keep doing a progesterone withdrawal test every month to restart my periods, and they said I'm producing too much prolactin. Know anything about that? I tend to flare on it and feel better after it's done for a week. Hun, this is an area of IC that everybody certainly understands happens. That, again, some patients have very strong responses to different levels of hormones, whether it be estrogen or progesterone. We just don't understand why. And so I wish I had more information for you. I just don't, because I don't understand it, and the vast majority of doctors don't understand it either. Angela says, my doctor has used several silver nitrate installations I've seen on your website where it's no longer used, and my doctor wants to keep doing these. What should I do? Honey, silver nitrate therapy is old, outdated. Man, you're talking back in the 50s and the 60s. Silver nitrate is caustic. It is potentially damaging to tissue. And so it is not a therapy for interstitial cystitis. It had never been listed. It hasn't been listed as a therapy for IC Oh gosh, in 20 years, it's not even mentioned in the AUA guidelines. And I think it's important as you think about therapies. There are some therapies that are effective because they are constructive. They are helping to build something, like helping your bladder wall protect itself with a coating effect, or giving that tissue or skin some estrogen so it can start building more mucus or creating more mucus. But then there are other therapies that work because they're damaging. So, as an example, hydrodistension. Hydrodistension, the reason why some patients feel better when they have a hydrodistension is because it temporarily breaks the nerves, right? So, of course, you're not going to feel a lot of pain. Of course, you're not going to feel a lot of frequency urgency because you've actually physically broken the nerves. The problem is the nerves grow back. They will always grow back, and sometimes more nerves grow back than you originally had. So silver nitrate, is basically one of the more caustic therapies. We used to call it a bladder stripper back years ago. They thought if you strip the bladder lining off, that a new healthy bladder lining would grow. And of course, now we know that IC, there's many variants in IC. But for those of you who have, for example, IC subtype 2 bladder wall driven from chemical irritation, the last thing we want to do is strip the wound or make it bigger. Now it's about wound care. We don't want to antagonize the bladder. We don't want to irritate the bladder. We want to calm and soothe the bladder and give the bladder what it needs to try to restore more mucus, right? And to restore the superficial integrity of the bladder wall. So it wouldn't be something that I would agree to personally. I think I would instead be talking to your doctor. I would just say, you know what, this isn't, now that I've read about IC and I've looked at the AUA guidelines, silver nitrate isn't even mentioned as a treatment. So what are you trying to accomplish with this? What are you trying to accomplish? Silver nitrate has been found to kill maybe fungus and maybe some bacteria and stuff like that. But gosh, it's just not used so much anymore. I mean, most patients who have silver nitrate, it's done under anesthesia, and it hurts like hell at times. Christine, let's see. Kayleen says, I'm still having frequency and pain while peeing. I know you're as frustrated as I am. Well, yeah. Michelle says, what do I think about microgen testing? I like data. I like facts. I like facts, my friends. And here's the challenge. The bladder only knows one language: frequency, urgency, pressure, pain. You could have a bullet wound and it would feel like infection. You can, hold on, this thing keeps falling. Stay. I have to. All right. So you could have a bullet wound and it would feel like infection. You could have a stab wound and it would feel like infection. You could have cancer and it would feel like infection. The only way that the bladder can tell you is that there are symptoms of frequency, is that it's the only way the bladder can communicate to you that there's a problem is through the symptoms of frequency, urgency, pressure, pain. Now here's the problem. When you have those symptoms, when we all have those symptoms, we're all going, gotta be an infection. Must be an infection. Right? I can remember my first couple years of IC. I must have had 20 or 30, urinalysis looking for UTI. And of course, in hindsight now, I realize it had nothing to do with infection for me. It's all pelvic floor driven and nerve driven for me. So, but if you just literally can't get it out of your head that you really believe you have infection, one of the ways that you can confirm that is with the next generation urine test, because that's going to use DNA, the DNA it finds in your urine, to identify everything in your urine: good bacteria, bad bacteria, fungus, and even potentially virus, depending upon the test you have. So it's just data, it's just information, but it's really valuable in patients who struggle with recurring UTI, where no matter what you do, it comes back over and over and over. I was working with a patient last week who, gosh, she's had like, how many antibiotics? She'd been on like 4 or 5 antibiotics. and it hadn't killed the infection, and it was an E. coli. And they just kept trying different antibiotics. And I said, well, did they do any testing to identify what drug resistances are present? And they hadn't. And that's where next generation DNA urine testing would be particularly valuable also, because it will help identify, you know, unusually drug-resistant infections. What they do is they take the the DNA profile that they get, and then they compare it with these very big databases, huge databases, where all this information is stored, all these random, weird, unusual infections are stored, and they look for a DNA match. And when they make that DNA match, they're also going to be able to tell you if you have any drug resistance genes. So for me, for example, what's so weird, I've had next generation testing done twice, is every single time I have a resistancy to amylase. Is it amylase? Or no, amikacins. Amikacins? It's a very unusual antibiotic, and I have no memory of ever being exposed to this antibiotic ever in my life. And every single one I've had has shown this specific drug resistancy. And so at some point in time, I either ate something that had that specific drug resistancy, or maybe or that had that specific antibiotic, or maybe when I was having surgery at some point in time, somebody gave that to me in an IV. I don't know. I don't know. But next generation testing, it's just data. The problem with the next generation testing is it's very hard to understand. Last year, Dr. Curtis Nickel, the top IC researcher in Canada, gave a big speech at the American Urology Association praising next generation testing, saying that it was truly the next step in urinalysis, that it was far more effective at identifying potential pathogens. So he predicted that we would not be doing urinalysis within 10 years or so, that it would all be next generation. I agree with that. I mean, I think that next generation testing is affordable and it's far more accurate than a typical urinalysis. But right now, it's not covered by health insurance, and right now there's a lot of people who, especially primary care doctors, who don't go to research studies, who just poo-poo it. You know, they just are not interested in it at all. My local Kaiser doesn't believe in it. It's like, guys, I'll pay for it. I'm not asking you to pay for it. Could you just sign the form? Because I'd like to see what's in my urine. And I had to really like go, what do you have to lose? Come on, I'm paying for it. I'm not asking you for anything. You get the data. And eventually I was able to convince my OBGYN to sign the form for it. But then the urologist refused to sign the form. Absolutely refused to sign the form. We don't believe in next generation testing here at Kaiser Permanente. And I don't understand the motivation for that. I really don't. I mean, it's just data. It's data. All the COVID testing that's done right now is next generation testing. The MAP Research Network, which is our premier IC chronic pelvic pain, chronic prostatitis research community funded by the National Institutes of Health, they use a massive amount of next generation testing. You know, but some of these local ones don't. And I have a couple of people who email me and tell me that they think it's a scam, and I just don't believe that. It's just data. It's interesting data. And listen, if it comes back negative, that you got nothing there, then you can walk away from the concept that you have UTI. If it comes back positive, then you can have some sort of discussion. If it comes back with fungus, and that's really one of the things that we really understand now, is that for some IC patients flaring, you might have candida in your urine. A typical urinalysis does not test for candida, but next generation does. And so that's kind of meaningful data. And several people have reached out to me. Many people have reached out to me afterwards to report that they too had a drug-resistant candida infection like I had. I had a drug-resistant candida glabrata infection. And Pamela here says she has candida yeast thrust in her body, was told to go to an infectious doctor. So far you can't get into one. You know, Pamela, if you go to the Center for Disease Control website, cdc.gov, and if you search for candida over there, I think you can find the latest information on the threat that candida poses. I mean, the Center for Disease Control considers drug-resistant candida infections in the top 10 worst pathogens affecting humanity, and drug-resistant pathogens. Generally, though, you get candida when you've used a lot of antibiotics over time. And the problem with antibiotics is you're killing the bacteria that normally control and keep the candida in checks and balances. The time I got my 2-year candida glabrata infection was after doing the Dr. Fugazzotto IC protocol, which was antibiotics for 6 months, which I massively regret. Massively regret. Sure wish that I got to be honest here. Candida in your urine is far more painful than a typical bacterial infection or even an IC flare from acid. Holy hell! When that candida my candida always flared if I ate anything with milk or milk sugar in it. It's like that night, bam, the pain was back again. And it makes sense because if you've ever made yeast bread, right? What do you do with yeast? You put it in warm water, give it some sugar, and within 5 minutes, it starts to grow and bubble. Well, milk sugar is an ideal sugar for candida to consume. And so, one of the very, very clear protocols for people who struggle with candida is to stop feeding the yeast, which means you got to cut way back on your sugar and you got to cut way back on your carbs. And I'd be fine for 6 weeks and then I'd give in and I'd have ice cream. I'd have a scoop of ice cream. Bam, that night, candida right back. And it literally took 2 years to get out of that with a lot of diflucan therapy and a lot of other things that we had to do. Miki, thank you so much for the 200 stars. Mandy, thank you so much for the 50 stars. Really, really, really appreciate your support. So Rhonda says, let's see. Hello, Sid from Texas. Hi, Sierra. Sierra, I did email you the magazine, honey. I emailed it to you like 2 weeks ago. I know for sure I did. Rhonda says, I'd be interested to know why it failed really. You think maybe they didn't try hard enough? I would think it helped just to have relief for a period of time. I guess Botox is much easier for them. What a shame. Hold on a sec. I mean, pretty much all they say in the abstract is that it just didn't meet endpoints. It just didn't show using the statistical analyses that they were using where they asked patient to rate their symptoms. There wasn't a difference between before they started versus after they started. It wasn't a significant difference in enough patients to be meaningful, I guess. I'm baffled because it was so exciting. And I still remember I had a patient call me who was in that very, very first study. And I didn't even know it was happening. And she called me from Canada. She goes, oh my God, my IC's gone. I was like, what? She goes, yeah, I'm in this new research study with this Lyris device. I'm like, what the hell's that? And she told me about it. And she said, you're not going to believe it, but my lesions are gone. They healed completely. And I was like, oh, really? I don't know about that. Hunter's lesions are very resistant to therapy at times in some patients. And she's like, no, believe me, I'm telling you right now, I'm in this study. And so I actually called the researcher and the research team. I don't remember exactly who I talked with. I think it was the clinical trial coordinator. I don't think it wasn't Dr. Nickel himself, but I think it was his clinical trial coordinator. And the clinical trial coordinator said, yeah, we're really excited. We're seeing really, really, really good data and really good results with Lyris. And they said, you don't say anything until we've published the study, though. So I sat on it for a year. And then finally they presented the data at the American Urology Association. And that's when I was able to go public. Say a complete and total resolution of the lesion. So I don't quite understand what happened. I just don't understand what happened. The concept's solid. Rhonda says, we need another trial from a different company. Well, the challenge is Allergan bought the technology. Terrace still retains rights to it. I think that they're using it for other diseases now. But the whole concept with IC, I think it's pretty much dead in the water at this point in time. And again, I have to change our website and pull it off of our website now. Hold on a second. Hi, Cindy. Pamela was told to try antibiotics number 15. Would that help? No, you need an antifungal. An antibiotic would not help treat a candida infection. An antifungal would be used for a candida infection, like diflucan or nystatin. I don't understand why they would say that. I think you really, Pamela, you need to work with that infectious disease specialist. Hi, Boria. Miri said, I did my first cystoscopy yesterday. What to expect? I don't understand your question. So, cystoscopy is what I call a looky-loo. It's an opportunity for them to look in your bladder very quickly to see if they see anything unusual. That would give them an opportunity to see if you have bladder stones. It would give them an opportunity to see potentially how red and inflamed your bladder is. And it's it's a looky-loo. I mean, you numb the urethra, stick the scope in, take a look around, pull it out, you're done. The challenge with a cystoscopy is that anytime you stretch the urethra, it tends to be quite uncomfortable afterwards. So the first couple of times you pee afterwards are not going to be easy. Anytime you put something in the urethra that's bigger than the normal size of your urethra, you're stretching that tissue. And so what you're going to find is the first time you pee afterwards is going to be quite uncomfortable. You really just have to what I did is I just made sure I had a lot of fluid in my bladder. I drank a big glass of water afterwards. And then you just bite your lip and you just pee through it. You find if you stop and start, you prolong the pain. It's just important to just kind of power through that first pee and know that it improves subsequently with everyone. I mean, that's what I did. That's what worked for me. Now, remember, I had about 100 urethral dilations when I was a kid. So I kind of became an old pro at having my urethra stretched. And, but I'm different than other people, right? So what might be easy for me might be hard for you, might be hard for you, might be easier for me. Hold on. Why is this falling? Well, here. That might make it too bright in here. All right. Well, it is what it is. Here, maybe I can do this. Will that make a difference? I swear the ghosts are in my room today. This is hysterical. Okay. Let's try this now. So what I just found for me personally is that my best strategy for dealing with a stretched bladder, a stretched urethra, was to make sure that I had a lot of fluid in my bladder and I just peed it out and just bit your lip. If I dribbled, stopped and started, it just kind of extended the pain longer. That's what I ended up doing. Be a good question for your urologist. Ask them what would be a good way to minimize that pain. Maybe you could use a little bit of anacream, a little bit of lidocaine cream at the entrance to your urethra. That might help a little bit too. Thank you, Julie. Pamela says, infectious doctor has been told to see one. They turn me away each time. Well, you should be a great challenge to them. I don't know what maybe what we can do is put together a packet with the Candida research, see if we could appeal to their academic and what's the right word? I mean, I don't know. They should want to see you. They should want to see you. It's weird. I don't understand why they wouldn't do that. I mean, it's such a problem. And the Center for Disease Control says it's a problem. April says, I go to the doctor tomorrow since having my hydro and I'm nervous. They took some biopsies, so I'm hoping for good news. Good. It's so important, guys. Listen, if you're worried about something, don't sit and suffer. Come on. If you're worried about something, call the doctor and ask. Get the test done. There's nothing worse than worrying about something for 2 months, 3 months, 4 months, 6 months, 10 months. If you got a spot on your skin and you don't know if it's melanoma, for God's sake, don't stay at home. Just go to the doctor and have them look at it. Save yourself suffering because, it's just you're allowing yourself to live in anxiety, and that's not a good thing. We got to get your brain out of fight or flight. We got to calm that central nervous system down to try to calm any pain down. The more anxious you are, the worse it gets. So if you're worried about something, just make the appointment and go ask the question. You can even do it by video. You can show them something on your skin by video. But the same is true for your bladder. You might be able to do that with your by video too. Pamela says the screen is freezing. Yeah, I just don't understand what's going on with Facebook right now. I've got 2 separate internets. On YouTube, which is when I'm looking here, you're on Comcast. Facebook is on AT&T. And the irony is that Comcast is the one that stops and starts. It stops and starts whenever I'm working. AT&T is more reliable. And yet, the Facebook AT&T interaction it has been really rough the last 2 weeks. Pamela says you missed the Candida package. Okay, so again, I don't understand why the infectious disease doctors aren't willing to see you. If you've got thrush in your mouth and you're not responding to typical antifungals and your doctor doesn't know what to do, then it's completely normal and appropriate for them to refer you to an infectious disease specialist. And the Center for Disease Control is very clear. Drug-resistant candida is killing people. We have to get on those early. They're very, very common infections in hospitalized patients who have been on a lot of antibiotics. But if there's ever a patient community that's been overexposed to antibiotics, it's us. It's a lower urinary tract patient. We've all been given antibiotics over the years for quote unquote our UTI, when in fact, for many of us, it wasn't UTI. I can still remember as a kid, I had to swallow 16 sulfas in one sitting. They were just feeding them to me. I was in 7th grade. It was crazy. Absolutely crazy. Mandy says, hard not to participate in Halloween this year and eating all the chocolate. I'm finding my willpower hard right now, but I will. Mandy, so I went to CVS yesterday, right? I went to CVS yesterday because I needed to get a little bit more candy. I don't know if we'll have any trick-or-treaters or not. I don't know. But I'm just going to put something out on, I've got my whole front door decorated, and you can see I love Halloween because I've got all sorts of decorations. And I've got a blow up dragon right out front, which is pretty cool too. I was stunned that they had white chocolate Kit Kats. They had white chocolate M&Ms. There were a bunch of white chocolate Halloween candy that would be completely bladder friendly for you. It's the milk chocolates. I call it the dirty chocolate. It's the the cheaper milk chocolates that tend to be more chemically processed and tend to be a bit more allergenic and irritating. I see patients do best with carob or white chocolate, or if you're going to do a chocolate, do a really, really super expensive dark chocolate. A really pure dark chocolate might be okay. I don't do chocolate because I get terrible bowel spasms when I do chocolate. I just won't touch it. I'm sorry. I have no interest in doing chocolate anymore. Cecilia says, my pelvic pain flares every night. I get up 5 to 7 times, 6 hours of sleep. I cannot sleep. Kaiser said there's no cure and they cannot do anything else for me. I'm very anxious and losing hope. All right. So Cecilia, you got to remember that a diagnosis of IC is not specific enough. It does not identify good therapies for people. Really, for the last 10 years or so, doctors around the world have been trying to define and study and understand the many variations in the IC patient population. Because here's the deal. Some of you have lesions and others have a completely normal bladder. My bladder, absolutely normal. You look at my bladder, it is a baby bladder. There is nothing wrong with my bladder. Right? And yet there's no doubt I had severe pain for years. Why? Right? That's the question. For some of you, IC begins in childhood. For others, it begins after menopause. Are you the same? No, you're not the same. For some of you, IC begins after chemotherapy or drinking way too much coffee or diet soda, while for others, IC begins after having a baby. Are you the same? Absolutely not. There are variations in this patient population. You cannot put apples, orange, bananas in the same group and expect them to respond to the same therapies. And that is why more than $100 million of research funded by the National Institutes of Health has failed, because they were not defining subtypes. They were putting everybody together in the same study. It does not work. And we finally now have an admission from the top doctors in the country who make those decisions that, yes, we can no longer mix all these patients in the same study and expect a good result. They're willing to say that there's a group of patients who are bladder centric and a group of patients who are beyond bladder. Okay. They're willing to go that far. But Dr. Christopher Payne, who ran the IC research program at Stanford University, said, hey, here's the problem with the diagnosis of interstitial cystitis, is it doesn't give you a clear treatment pathway. You have no idea what to do with a diagnosis of IC. You walk out of the doctor's office, they give you the diet, they give you Elmeron or GMSO, and they say, hey, we'll see you in 6 months. And you're like walking out going, what? What the hell is this? What am I supposed to do? And he suggested that we treat IC patients like cancer patients. Now, that was scary at first. You know, it's like, oh my God, don't say cancer and scare people. But he makes a very, very important point. When somebody's diagnosed with cancer, they get a very clear diagnosis. You have cancer of the left breast, and it's estrogen dependent type 1, 2, 3. And both the doctor and the patient know, based upon the type of cancer that patient has, exactly what their treatment options are. There's no, hey, I'll see you in 6 months. There's a very clear, intuitive pathway. And he argues that a diagnosis of IC leaves both the doctor and the patient going, what do we do next? There's no clear, intuitive treatment pathway. So what should we do next? So how do we get a more individualized diagnosis? It's with a more specific diagnosis. We got to go another step. It's like, okay, this patient has bladder pain, chronic pelvic pain, or urologic chronic pelvic pain. That's what they call, and now they're calling it primary bladder something. Okay. But we need to understand why. We have to understand cause versus effect. The pain is the effect. The frequency urgency is the effect. We got to really try to understand cause. What could be triggering this? So he starts with 5 fundamental subtypes, that there are 5 distinct variants. And then there are little variations inside each subtype. And he believes that there are probably more subtypes out there that we haven't even defined yet. So he starts with 5 core subtypes. Subtype number 1, Hunner's lesions. If you've got big bloody wounds in your bladder, they're known for bleeding like a waterfall of blood. They call it the waterfall effect. That's Hunner's lesions. Hunner's lesions have now been linked to, oh yeah, well, there was one other study. It reminds me. Hunner's lesions have been linked to viral infections. They have been linked to neuroinflammation. And then there's another interesting case I don't need to get into. Hold on a sec. There was a research study. Hold on. We have another research study that found virus and parasites. Okay, where the hell did I put it? Hold on. Where did I put it? That's not it. Oh, come on. Where did I put it? Where's my research? That's not it. That's not it. See, I closed a whole bunch of windows. That's not it. It was like a genomic study where they were looking at, okay. It was the artificial intelligence genome study that was like done in China. And in that study, they were also able to establish or predict that some patients could have a viral infection in their bladder. And that supports the data that we have from Europe and now also in the United States, that there is a very, 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 very small group of IC patients who do potentially have viral infections in their bladder wall. COVID is actually one of those viruses. So again, IC subtype 1, Hunner's lesions, worst form of IC, now associated with a viral infection potentially, as well as other things. So of course, Elmeron would not work for that, right? It certainly would not work for that. IC subtype 2, bladder wall driven. These are the patients who have a legitimate bladder wall problem. So this is the chemotherapy patient where the chemicals from the chemotherapy damage their bladder wall. Or this is the ketamine patient, patients using ketamine for pain relief or recreationally. Ketamine, it acts as an industrial solvent to the bladder if you use it in a high enough quantity. So the bladder can be injured. And when the bladder is injured, patients get frequency, urgency, pressure, pain. And our therapeutic priority for this patient is to figure out what the hell is injuring the bladder, stop it, and give the bladder time to heal. But another variant in this IC subtype 2 bladder wall driven is estrogen atrophy. Estrogen atrophy, that if you are on birth control, if you are put into chemical menopause from Lupron, if you've had a hysterectomy, or you happen to be an older, wiser woman like myself, then because of the loss of estrogen, your bladder wall is not as thick. The mucosal barrier is not as thick as it would be. Your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. And the purpose of that mucus is to protect the tissue. It's protective. Unfortunately, it's estrogen dependent. So when you're young and you have lots of estrogen, you got lots of mucus, and you can get away with drinking a lot of soda and coffee. But when you're older, or if you're in menopause, or you'd had a hysterectomy, bam, you have much less estrogen, you have much less mucus. That's not a disease, that's getting older. That's called estrogen atrophy, or the genitourinary syndrome of menopause. So for these patients, our therapeutic priority is to try to protect the bladder wall. Diet matters to these patients. And maybe give them some estrogen that will give the skin what it needs to produce more mucus, as well as maybe doing a bladder coating therapy, something with chondroitin in it. This is where Elmeron shined, although of course now with Elmeron and the eye issues, it's just fallen out of favor. The third variant in IC subtype 2 bladder wall driven is chronic infection, chronic UTI, bacterial infection, or fungal infection. These are possible. There are some people online who say everybody has chronic infection, chronic bacterial infection. I completely disagree with that. I don't know any major IC researcher who would ever support that because of these clear variations. I mean, we have the data now, which has proven that some of you have viral infections. So that completely throws out the chronic bacterial infection theory. And we also have to look at causation for the patients whose symptoms began, after having a baby, after falling on their tailbone, breaking their tailbone, something like that. Or if they have fibroid tumors pushing on their bladder, or endometriosis on their bladder. Those are clearly not chronic infection. IC subtype 3 is pelvic floor driven. So these are the patients whose symptoms began after falling on their tailbone, or they have a history of athletics, repetitive trauma. If you were an ice skater, a gymnast, a dancer, a football player, a wrestler, anything that reinforced a lot of trauma. If you were a big bike rider, motorcycle rider, that could cause pelvic floor tension. Pelvic floor tension will cause bladder symptoms. It will cause all the symptoms that we associate with IC, frequency, urgency, pressure, pain. Our challenge here, though, is that bladder therapies are pointless, because our therapeutic priority for this patient is to relax the muscles, restore muscle tone, and restore blood supply. It's all about circulation and blood supply. Tight muscles restrict blood supply. We've got to relax them. IC subtype 4, pudendal neuralgia. Pudendal neuralgia, it means that the pudendal nerve is being compromised in some way. So if you have pain when you sit down that is relieved by standing up, that's suggestive that when you're sitting, a nerve might be compressed. If you have pins and needles, if a pins and needles sensation somewhere in your crotch, on your labia, and your perineum, around your rectum, etc., that's really going to be nerve driven. If you have areas of numbness, that's also nerve driven. So our therapeutic priority for these patients is to try to figure out where the nerve is being compromised, and then we want to calm the nerve down and we want to relax the muscles. And then last but not least, chronic overlapping pain conditions. That's a whole nother story, because chronic overlapping pain conditions, if you have IC, IBS, vulvodynia, fibromyalgia, if you have 2 or more of those, your new diagnosis is chronic overlapping pain conditions. And it is characterized by having a wicked sensitive skin and a wicked sense of smell. If you smell things, if smells bother you, you smell things other people can't smell, and smells really have the potential of driving you crazy, that's a brain function. That's a central nervous system function. If you struggle with anxiety disorder, if you're living with constant anxiety, that's also part and parcel of this subtype. This is one of my subtypes. And what the research has shown in this group is that the central nervous system is stuck in fight or flight. The brain is stuck in fight or flight. It's not a mental illness. They do not call it a mental illness. It is a maladaptation, a central nervous system maladaptation. It means that the brain has become habituated to fight or flight. It thinks it's supposed to be in fight or flight every day, every minute of every day. And what the research studies show is that for 80% of the children that this happens to, and remember, this began for me in childhood, that there was a major physical trauma, like getting hit by a car, breaking a leg. In my case, I broke my tailbone badly. And then for the other 20%, there is a history of abuse or bullying. And that's the best way that I can share with you how the brain gets stuck. Because imagine that your child or you had a very, very bad bully at school. I had a bad bully at school. Hello, redhead. Every redhead goes through this. But my bully at school hurt a lot of people, and he ended up raping and murdering people. So really mentally ill. So going to school was scary for me. As soon as I walked out the door, I was in fight or flight. Absolutely in fight or flight. The closer I got to school, the worse it got. It's like, oh my God, where is he? There's his friend. Oh my God, he's got to be close. There's his friend, right? He had his little circle of buddies. And I was in fight or flight all day. And the only rest that I got was when I got home at the end of the day. I had 3-4 hours at home. You're back home. The bogeyman's not going to get you, right? It's going to be okay. And then mom says, hey, got to go take a shower. Got to go to bed tomorrow. Got to go to school tomorrow. And you immediately go back into fight or flight. And so what the research studies show is that 15 to 20 days of that changes the brain, and it can put you into habitual fight or flight. Your brain is just kind of stuck in fight or flight. However, 20 days of mind-body medicine completely reverses that damage and corrects that damage. And so heightened fight or flight is heightened central sensitization. It means that everything gets more sensitive in your body. And of course, with anxiety intensifies pain. And so you get stuck in this vicious loop of anxiety, sensitivity. So now we're treating chronic overlapping pain conditions very, very differently. Our therapeutic priority is to get these brains out of fight or flight. When we get the brain out of fight or flight, things calm down. The pain improves dramatically. And we also have to calm the anxiety and learn some really good anxiety management skills. And I will say very, very, very honestly that at my very first appointment for IC, my very first appointment at Kaiser Permanente with my employer back then, with the urologist, he said, I'd like for you to go learn about mind-body medicine from the psych department. And I was horribly offended. I went, no, I don't sleep at night. Like, I'm getting up every 20 minutes to pee. This is my bladder. This is not my mind. Please stop it. I need help for my bladder. I need to be able to sleep. And I just threw him under the bus. Ironic, I had a master's degree in psychology. I didn't understand that connection. A lot of this is really, really new stuff, right? This was 30 years ago. And so I blew him off. But you know what? He was absolutely right. He could see the pattern. I had the IC. I had IC, I had IBS, I had vulvodynia, I have TMJ, wicked sensitive skin, wicked sensitive sense of smell. I am the case study for central sensitization, chronic overlapping pain conditions, and I had severe anxiety in my 20s and early 30s. Emphasis on the word had, because I finally went, I can't do this anymore. I used to have panic attacks going to the doctor. In my backyard, I'd be walking around crying, having a panic attack because I didn't want to go to the doctor. And And I finally one day just said, I can't do this anymore. I need help. I don't know how to cope with this. And I took an anxiety management class that completely changed my life. And it taught me how to control anxiety. And it taught me how to control adrenaline so that I don't live in fight or flight. I'm very attentive to my thoughts now. If I have negative thoughts, I know exactly what to do to stop it. And I have not had a panic attack since I took that class. So our therapeutic priority for the chronic overlapping pain patient is very different now. We want to calm that central nervous system and get you out of fight or flight. It's a huge part of the puzzle. You could be focusing on, I mean, we could be doing your skin, we could be doing your bladder, we could be doing bowel therapies, we could be doing TMJ therapies. But in the end, as long as you're in fight or flight, your pain's going to be worse. So we've got to get you out of fight or flight. Sierra says, I didn't know white chocolate is bladder friendly. Yeah. Rhonda says, I hated Jill. I have very bad IC and menopause. From what I hear, isn't helping to come so far. You would love to know what it's like to throw on jeans. Yeah, honey, it sounds like you've got extreme estrogen atrophy, Rhonda. Are you using any topical estrogen? I can wear jeans now. I couldn't wear jeans in my part of my 20s and even my early 30s. I can now. My skin's pretty solid now. Mireille says, I've been having physical therapy for the bladder and I like it. What are your thoughts? Excellent. I think it's excellent. Pelvic floor physical therapy outperforms bladder therapies in research studies. We knew that in 2008. That was the moment that the IC world moved from bladder centric to beyond bladder. Is when the research study showed that pelvic floor physical therapy was successful. Everybody went, uh-oh, maybe this isn't just a bladder disease for some patients. Maybe for some patients it's muscle driven. Megan says, I've had IC since I was 16. I'm 33 now. Yeah, I think I had my first symptoms of frequency urgency when I was 13. Mandy says, that's good to know. Any white chocolate tonight is mine. Yeah, you have my permission to go through your kids' candy bags. And if they've got any white chocolate, you grab that sucker. Makita says, what causes a random feeling of contractions? It's very painful. Pelvic floor. I mean, there are two distinct muscle groups that can contract: your smooth muscle of your bladder wall versus the skeletal muscle of your pelvic floor. There is a condition called proctalgia fugax. Proctalgia fugax. That is a sudden, random, agonizing spasm of the muscles by your rectum. And it will last for 5 or 10 minutes. You're literally stopped in your tracks, and then it goes away. And that is really now Dr. Jerome Weiss in his book, Breaking Through Chronic Pelvic Pain, links that directly to tight pelvic floor muscles, compromising nerves. Marie says, do you have any advice for someone who's going to a hearing for SSDI? Yeah, be yourself. Don't dress up, be yourself. Don't be ashamed. Don't be intimidated. This is where I see patients win, is they win at the hearing because they get to see you and you get to describe how your life is limited because of this. So, in addition to explaining what your symptoms are, I think it's very important to focus on your functions. You need to say, listen, I haven't had a full night's sleep in 5 years. I am up every 30 minutes. Here's my voiding diary to prove it. If you could do a voiding diary for a couple of days before your hearing and bring that with you, that's good information for a judge to look at. So if you have a job like driving a truck, what requires you to be very on mentally and be very, very alert, then something that keeps you sleep deprived would disqualify you from that job. But tell them what it feels like when you drive. Tell them that you have to go to find a restroom every 5 or 10 minutes. Tell them that the longer that urine is in your bladder, the more intense the pain becomes. So it's not like you can just hold it. The more you hold it, the more you're reinforcing pain, the more you're worsening that pain cycle. Can you go to church? Can you shop? Can you stand? Can you clean? Can you make meals? Tell them all the ways that your symptoms interfere with your ability to function. Remember, Social Security disability that is a disability program that you pay into, right? It is a disability insurance that is withdrawn from your paycheck. The assumption when you apply to SSDI is that you will not be able to work for the long term. And so it's not short-term disability like state disability where they want you to get working again, and you can start working when you're getting state disability. You report your income and they adjust your state disability check. Federal disability, you cannot do that. The assumption is you cannot work at all. Come on over to the IC Network website, icnetwork.org, icnetwork.org, and go to our disability center, and you can read a couple of articles from other patients who have gone through the hearing and hear how they approached it. Okay, hon? Veronica says, I'm sick of having IC. Yep, I get it. I don't know. I do a lot of, I'm really I think that I'm pretty well adjusted. I understand my life, and I have found a way to function despite years of having to deal with this. And my condition is much, much better now that we know what's wrong, that it's really central nervous system and muscle driven for me. But gosh, there's a part of me that I would just to be able to love to go back in time and fix whatever triggered all of this, that fall on my tailbone and or the bullying and or the red-haired genes, listen, God didn't promise us when we were born that we would not be hurt. Injuries happen. That is life. Any animal on this planet can be hurt. Any animal on this planet, including humans, can develop a disease. It is the price of life. And it is what we do with that really matters. But you're entitled to be sick of it. You just don't live there. You can be sick of it for an hour a day. And then after that hour is done, you got to get up and do stuff. You can't live in that. You cannot live in that space of being sick and angry. You got to get up, move around, focus on other things. The past is over. It's done. We can't change it. It's pointless to focus on it. It's pointless. It's wasted energy. We have to focus on today. What can we do today to change our life? What can we do today to give our body some comfort? What can we do today to help improve our muscle tone? Have you gone and laid down in your living room and done the work you need to do to relax your pelvic floor? Have you done that yet today if you have pelvic floor tension? It's about being consistent every single day. Nobody wants you to make big steps. This is not about making a big, giant step. This is about little steps, being consistent with little steps every day that over time will get you to a better place. Lisa says, do you recommend cystoscope with hydrodistension when you're not sure what's causing my IC and or embedded infection? I've been on antibiotics and they seem to work for me, but a few weeks later, symptoms return. Well, if you believe that you have embedded infection, I think a next generation DNA urine test would be really interesting because that's going to tell us if you do have something funky going on there, right? It would be interesting data. Having hydrodistension with cystoscopy is only recommended if the diagnosis is in doubt and the doctor doesn't understand why you're having the symptoms you're having. And giving them an opportunity to look in your bladder is reasonable. Otherwise, you're forcing them to guess, and I don't like guessing. So, seriously, if you're peeing blood and you've been peeing blood for 2 months, for God's sake, you want somebody to look in your bladder to see what the hell is bleeding, right? So there comes a point in time where it's important to let somebody look to rule in or rule out. The challenge with the hydrodistension is it is a bit traumatic. It can be traumatic to the bladder. In the old days, they did something called a high pressure, long duration hydrodistension, where they really stretch the bladder for a long period of time. And of course, the worst thing you can do to a hollow organ is stretch it, which is why a hydrodistension is always done under anesthesia. Here, hold on a sec. Yeah?
A frayed section of the paper.
Didn't see it. Okay, so when you stretch the bladder, that can be remarkably painful. That's why it's always done in the hospital under anesthesia. It's as an outpatient procedure. In the old days, they did something called a high pressure, long duration hydrodistension, where they stretch it for a long period of time. Of course, unfortunately, in some people that ruptured their bladder. If you ever had a hydrodistension and they sent you home with a catheter, that means they damaged your bladder or ruptured your bladder. And it's remarkable the number of patients who were never told that. You're not supposed to go home with a catheter. But today, the American Urology Association doesn't want doctors to do that anymore. They acknowledge that bladders were harmed. They acknowledge that patients were harmed by that. They are asking urologists to do something called a low pressure, short duration hydrodistension. So we're only stretching the bladder a little bit for a very brief period of time, just for the purposes of looking. So I had that 4 years ago, and it was fine. It was fine. So, and I had mine after I had my hysterectomy to make sure that they hadn't put a stitch through my bladder wall or had damaged my bladder in some way. But understand, Lisa, the whole embedded infection theory is controversial. I do believe that some patients could have chronic UTI. I do believe that, but not everybody. You also have to remember that antibiotics have a gentle anti-inflammatory effect, and so that's why some patients feel better when they have antibiotics. Not that it's killing anything, it's that it's kind of reducing some of the inflammation. At least that was one of the old theories. So number one, confirm how they're going to do it. It should be low pressure, short duration. Number two, I think it's very important to ask about pain care. Some patients walk out of hydrodistensions and they're fine and they can go out for dinner. Other patients, especially years ago, were in bed for 5 days. I think it's absolutely reasonable to ask for a couple of days worth of pain meds. I mean, you certainly don't need a month's worth, but maybe 2 or 3 days worth of a pain medication to get you through a difficult moment would be reasonable. If after you have a hydrodistension, your symptoms get worse, like on day 2 or day 3, you're profoundly worse, and the pain is off the charts, that means you could have picked up a post-operative infection or a nosocomial infection from the hospital. That also is a fairly common side effect that can happen anytime anybody puts anything metal in your urethra up into your bladder. Last but not least, in your pre-op appointment, you need to have a conversation with your doctor about Hunner's lesions. Because if the doctor does a hydrodistension and he finds lesions in your bladder, you need to say, what are you going to do about those? How are you going to treat them? And if the doctor says, well, I'm not going to treat them, you're going to say, why? Why? Why wouldn't you treat them? Hunner's lesions respond beautifully to lesion therapy. They do. So the tragedy of not treating the lesion at the time is that's leaving that patient in pain for a period of time. And inevitably, you will have to eventually have a hydrodistension again so that they can treat the lesions either by cauterizing them or injecting a steroid into it. And now we've got the glow. Hold on. All right, everybody. Stand up, stretch it out. Stand up, stretch it out. Oh. Let me tell you, these muscles, I really now know to pay attention to my muscles much more. This is my Lady of Shalott dress, or my medieval dress. I love it. All right. Tony says, my gynecologist claims that compounded vaginal estrogens are unreliable. She recommended a 6-week course of Premarin and then revisit. Well, the problem with Premarin is it comes from, okay, why is that worse? Is it comes from pregnant mare urine. And they have to have a lot of extra preservatives in it. Hold on. Gosh, man, I'm telling you, the Halloween gremlins are in my office right now. What is going on here? Whoa. All right, let's see if that's any better. Yeah, that's a... Is that better? Okay, that's a little bit better. Oh, for goodness sakes. There's a lot of controversy over compounded pharmacies in general. There are some poor compounded pharmacies that have been penalized by the government for unreliability, and they've even been shut down. But there are some really, really reliable compounding pharmacies with a very, very strong track record, like the Women's International Pharmacy in Arizona, which is where I get mine from. But some doctors are for it and some doctors aren't. If she says she's not willing to go for a compounded estrogen, and if Premarin is irritating for you, then I would be asking her, is there another gynecologist in the clinic who will support my prescription? That's exactly what I had to do at Kaiser. My old gynecologist, Dr. Bennett, wanted me on compounded estrogen. He said, you're sensitive. I only want you to use this one. I used it for 10 years. And then bam, he retired. The new young gynecologist didn't believe in compounded, and the same thing. And I just went, no, I'm not interested. I've been doing this for 10 years. I want to continue to do it. And she said, well, I'm not going to give it to you. And I said, all right, then send me to a gynecologist. Is there another gynecologist in clinic who will? And she goes, yes. So it's weird. Helen says Facebook's cutting out a lot. I'm sorry, honey. Facebook's getting real weird. Julie says, excellent. Do we give fight or flight? Yeah, we do. Mind Body Medicine. Michelle says, I had estrogen-fed breast cancer. Can I take the estrogen you're talking about? Generally, the research shows that topical estrogen, that means estrogen used on your skin, is remarkably safe. And the risk of cancer is considered quite low. I would encourage you to Google or search for topical estrogen safety. There's a wonderful gynecologist on Twitter. Her name is Rachel Rubin. Rachel Rubin, R-U-B-I-N. I would ask you to maybe follow her on Twitter. She talks about this a lot, but ultimately this is a conversation between you and your doctor. Carissa says, what's the best way to find a doctor who specializes in pudendal nerve issues? I love Dr. Weiss' book. Thank you for recommending. Yeah, man, Dr. Weiss' book, in my opinion, is the best book ever written for pelvic floor stuff. I mean, it's just fantastic. For those of you who don't know what I'm talking about, it is this book, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. So for anybody with any musculoskeletal issues, bad hips, bad knees, bad feet, bad pelvic floor muscles, SI issues, this is the book to have. If you've got IC and if you got orthopedic issues down there, muscle issues down there, this book will help tremendously. It's such a good book, and it's free on Kindle Unlimited. So seriously, no excuses. It's freaking free. But if you want to buy it, you can buy it in the IC Network store for $29. I like to buy books because I like to mark them up. I mean, you can see all the highlighting I did on different sections as I went through this. That's how I learn, is I have to highlight. I got to do colors and stuff. Tyler says, why do all physical therapists buy me not take insurance? Is very limiting to patients. Well, I mean, this is where you have to almost petition the health insurance company, and get the physical therapists mobilized to try to encourage that health insurance company to cover. Uh, it took Kaiser Permanente years, like 10 years to do it, but they finally started training some of their staff in pelvic floor PT. It sucks. If money is an issue and if money's keeping you from going to PT, what I would just say is if at all possible, go once so that they can do the diagnostic evaluation so that they can at least tell you which muscles are the problem. And you want to walk out of that clinic with the name of the muscle. Is it the piriformis? Is it the obturator? Whichever. And then they will also give you some exercises you can do, and you just got to be real honest because they hear this all the time. It's like, hey, this isn't covered by insurance and I can't really afford it. I might be able to come back in 6 months. So what I'd like to do is take your exercises and take the name of the muscle, and I'll do some research on Google. Maybe you can recommend a book or two for me, and then I will try to come back in 6 months for a progress report. The most important part of physical therapy really isn't the physical therapy visit, except the first physical therapy visit is critically important because you'll never figure out which muscle group is. You need help with that. But once you start going to physical therapy routinely, it's really what you do when you get home from physical therapy that's the most important. I mean, I'm back in physical therapy because my muscles right by my tailbone on my right side are just like as hard as a rock right now. It's so frustrating. And they got hard when I hurt my back. So it's like, and she was doing my evaluation last week and she goes, your left side's fine. Your right side's great in the front, but holy hell in the back. Woo, this is hard. And I know. What do we do about it? And, she gave me more exercises to do, and I've got to be religious in doing them. Like 3 days ago, it was really bad. Like, seriously, I was using a lidocaine cream down there. Everything hurt so bad. And then yesterday, I started my day doing my pelvic floor work, using my wand and really targeting that muscle and working on that muscle. And you know what? I had no pain yesterday up until the very, very end of the night. Like, I went all day with no pain, no rectal pain, no pelvic floor pain. It was like, yeah, baby. And I meant to do it this morning. I just couldn't get to it this morning before starting this. So you getting in there and working with those muscles and releasing those muscles is the most important part of PT. Anne says, do I think vaginal atrophy causes IC flares? Yeah, absolutely. Because if you've got estrogen atrophy, your skin can't defend itself. There's not a thick coating of mucus anymore. So you are going to be much more likely to have a flare from a chemical irritant or a food if you're in estrogen atrophy. The other reality with aging is your muscles get weak. Our muscles start to get weaker. Rhonda says, Rhonda's asking me if mine is compounded. Yes, mine is compounded. I get mine from the Women's International Pharmacy. It's an estradiol cream. The reason why mine is compounded is because my gynecologist at the time already knew that I was super sensitive. I mean, I was like the case study for him of sensitive nerves. Remember, I already had vulvodynia. I had severe vulvodynia in my 20s. My skin is just uber, uber, uber sensitive. And over the years, I saw him for about 20 years. 9 times out of 10, when I went and saw him about something, he's like, Jill, it's your nerves. You're fine. It's just the nerves in your skin are really, really sensitive. So when it came time for me to start using an estrogen cream, he said, listen, I already know how freaking sensitive you are. We're going to the best formula for you. And that is a compounded preservative-free formula from the Women's International Pharmacy. And that's where he sent my prescription. And I've been getting my prescription from him ever since. He's like, no, I'm not doing Premarin. I'm not doing any box for you with preservatives. You're too sensitive. And my sister's just as sensitive as I am, and my mother too. Elle says, my doctor won't accept that the pelvic floor physical therapy isn't helping me. I've spent $1,200 this year alone, and it does nothing for my bladder or It does nothing for my bladder or pain for my uterus and rectum from endometriosis. I'm at a loss as to what to say to her. She makes me feel like I'm lying, like I don't want relief. Any advice? So, Elle, you know, there's kind of cause and effect, right? So your symptoms are the effects, and we have to understand the underlying cause that's driving those symptoms. The harsh reality here is that you've been in pain for a long period of time. And the way your body responds to pain is through the guarding reflex. Your muscles will always get tight when you're in pain. That is entirely subconscious. You have no control over this. If you were to step on a nail, aside from lifting your leg up, your brain says, don't move it. If you break your arm, your brain is like immediately holds everything in place. That's called the guarding reflex. So we have a guarding reflex in the pelvis. And so concept number one is the fact that the pelvic floor physical therapy might at least keep you out of getting tighter and tighter and tighter because of your pain. So it would be helping in that respect. The question that I would have for your physical therapist is your muscle tone changing? Is your muscle tone changing? Right? And so you've had physical therapy for a year. I think the question with her is okay, then are the muscles better than they were when we started? Or are the muscles getting tight over and over and over again? So again, in my case, it used to be the left side of my pelvic floor was screwed up. And it still occasionally gets screwed up if my SI joint gets all wacky. But the left side now is fine. It's like soft, it's pliable. Now it's my right side that there's one section that's hard as a rock. And as long as that muscle is hard, it's going to prevent good blood flow. It's going to limit blood supply. And that's not good. We need good blood supply for healing. But there's also the concept of the chicken versus the egg. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? The reality is that they're both involved. They cannot not both be involved because they are so interconnected. But one is normally driving the other, right? One is normally driving the other. So for some people, IC begins, let's just say, with chemotherapy. And because the chemo is badly damaging their bladder, their muscles get tight to protect them from the pain. So our therapeutic priority for that patient is we got to calm and soothe the bladder. Once we calm and soothe the bladder, the muscles should release and relax. But there's another group of patients whose symptoms began after muscle trauma, where you fell and broke your tailbone, your muscles got tighter and tighter and tighter. You've now got ischemia. The bladder wall starts to break down because it doesn't have good blood supply. Now you have no freaking clue you have a muscle issue. Your first symptoms are frequency, urgency, pressure, pain. You call the doctor, hey, doc, I got an infection. Doctor goes, okay, here's some antibiotics. Well, especially in the old days, they just give you antibiotics over the phone. The antibiotics don't work. You go back to the doctor, hey, it's not working. Doctor goes, okay, we better test your urine. They test your urine. Comes back negative. But sometimes they'll go, yeah, well, let's just do some prophylactic antibiotics for 6 months anyway. Doesn't work. You go back to the doctor. The doctor goes, oh, maybe you've got overactive bladder. They give you overactive bladder meds. They don't work. You go back to the doctor, and eventually the doctor gives you the IC. I hate to break it to you. I think you have this really awful, incurable bladder disease called interstitial cystitis. Here's the diet. Here's some Elmeron. I'll see you in 6 months. And you're like going, what the hell? But you're a good patient. You do it. You follow the diet. You take the meds. 1 year, 2 years, 5 years, 10 years, 15 years, 20 years. Are you better? The answer is for many patients, no. Why? Because the bladder isn't the cause. Bladder therapies will never fix a muscle dysfunction. Bladder therapies will never restore blood supply. Our therapeutic priority for somebody with a muscle trauma is to restore blood supply. And the way that we do that is by relaxing muscles. Here, hold on a sec. I just got a text. Here, hold on. Hold on a moment. Somebody wants to drop by to see my folks. It's always, God, it's so hard with COVID. All righty then. Well, hey, man, if my nephew comes over with their kids, I'll bring him in so you guys can see their costumes. Here, hold on. Give me a quick sec. Hold on. Oh, it's so stiff. I get so stiff when I sit. Hey, guys. Mark is asking if they can come over quickly. I guess they have the kids in their costumes. Oh. But you would have to button everything. I'm working right now. I won't be able to help much because I'm streaming. Mark and Jenna and the kids are down here for a Halloween party. And they were thinking about stopping by to say hi. Do you want to do that? You want to? Yes. Well, then you would have to straighten up. You have to straighten up a little bit, right? Good. How do you want to get all this done? All righty. Sorry about that. All right. All righty. Oh, the joys. The joys. Okay, so Elle, listen, to finish how I was responding to you. What makes you unique is that you've got the chicken or the egg is almost too simple for you. Yours is the chicken and the egg and the endo, right? And so if your endometriosis is the foundation that's driving all of this, then and driving your pain and driving your bladder symptoms, then bladder therapies and physical therapy are not going to be as effective as you would like for them to be, right? And so I guess what I would do if I were you is, and this is just something that I'm really focusing on here when I'm working with patients, is cause and effect. It's like, okay, doctor, listen. So we've done the muscle work for a year, but the reality is my pain level's not changed. The reality is I'm still getting up at night. And the reality is the physical therapist says my muscles are in good shape. So if that's the case, then we really need to start thinking too about what else could be causing some of this pain. Could it be endometriosis that needs to be removed or needs to be treated in some way? I mean, so your case is definitely a little bit more complex. Could you have endometriosis on the surface of your bladder? Could you have a fibroid tumor also that could be pushing on your bladder? It's again, cause and effect. The pain is the effect. We have to try to figure out the underlying cause. Now, there are quite a few people who believe that the long-term chronic issue for the majority of IC patients is something called ischemia. Ischemia is oxygen deprivation through tight muscles. And in fact, so I attended the International Pelvic Pain Society meeting last weekend. And it was, and I've got all my notes, and I'm going to rewatch the whole thing, and I'm going to feature it in my next issue of the IC Optimist magazine in our winter issue. They had an interventional radiologist as a speaker, and it was really interesting because it was kind of like, there's always competition between specialties. And so, some gynecologists don't want urologists to tell them what to do, just like urologists don't want gynecologists to tell them what to do, right? Now you're bringing in a radiologist, and it's like, oh, I don't know if I want you to tell me what to do either. And he prepared really just a stunning seminar on pelvic congestion syndrome. So pelvic congestion syndrome is characterized by feeling a heaviness in your pelvis as the day goes by. You start the morning okay, but as the day goes by, you feel more and more pressure, heavier, until by the end of the day, you're like carrying this giant bowling ball around in your pelvis. And what that is accumulated blood in these varicose veins. And I worked with a lot of patients over the years who have had that. Like, what is this heaviness? And, I kind of, it's just showing how dynamic things are going. Now we're really understanding the intricacies of the different things that can do that. So not only can muscles affect the bladder and nerves affect the bladder, but veins and arteries can also affect the bladder. So if you've got you've got varicose veins that are much larger than they should be, what happens is they then compress other veins. And he was showing radiographs of what happens to blood supply and how this one big vein or artery will now completely flatten the next vein or artery. And now you're looking at terrible blood supply on one side of the pelvis and too much blood supply on the other side of the pelvis too. So, but the other thing that he talked about with pelvic congestion syndrome is gravitational symptoms. Another symptom that we see is that if you're one of those patients where as soon as you stand up, you're uncomfortable, or standing for 2, 3, 4 minutes is uncomfortable, or moving is uncomfortable, that's also potentially a sign of pelvic congestion syndrome. It's very, very interesting. Lisa, thank you for the 99 stars. Much, much appreciated. Elizabeth says, for you to recommend Urabel, Prosed, DS, or some other medication, which one would you recommend? I forget all the ingredients, but they all contain methylene blue and are supposed to numb the bladder. Well, I mean, if you're IC subtype 2 bladder while driven, then a medication like that might be useful in terms of calming some of the ingredients. I mean, calming some of your symptoms and some of the superficial irritation on the bladder. It's worth a try. I don't really have a preference one way or the other. Rhonda says, Jill, I suffer from that heaviness, the pressure. I go from one extreme to the next. It's called pelvic congestion syndrome. Yes. Look it up, pelvic congestion syndrome. Terry says, I have several of the type 5 components, including the heightened sense of smell. How can that be part of IC? Because of central sensitization. So the characteristic is that the central nervous system is in heightened and extended fight or flight. The nerves now have become much more sensitive. It's a very primitive response to stress and stressors and our brain perceiving that our life is at stake. So people who have central sensitization, we often have something called small fiber polyneuropathy, which means that the smallest in diameter nerves in our skin are the ones that are the most dysfunctional. They're the ones that are triggering the pinpricking sensations on our skin. If you ever have that trying to go to sleep and you're like, you get pinpricked on your foot and then on your shoulder, just random little pinpricks, it's a really good sign of small fiber polyneuropathy. That's something that I have. So we have sensitive nerves in our skin, we have sensitive nerves in our stomach, in our bowel, and in our bladder. And so that's that nerve sensitivity. Irritable bowel syndrome in particular, the nerves in the bowel become hypersensitized. And there's a fabulous website called Help for IBS where she explains that. One of the reasons why patients with IBS cannot do insoluble fibers like granola is that the rough surfaces of insoluble fiber kind of drag along the bowel surface and it irritates the nerves. Same thing with lettuce. Like literally, if you got IBS diarrhea and you eat something and 30 minutes later you've got the runs, that's really a classic sign of very, very exquisitely sensitive nerves. So one of the things that Heather says over on Help for IBS is never start a meal with a salad, because lettuce has rough edges. Even though it feels smooth to you, it's actually provocative to the nerves. If you're going to have salad, you got to have salad at the end of the meal. The first thing that needs to go in your mouth at any meal is something that's comforting and soothing, like a roll, you know? So it's all connected. It's all connected. Terry, when I think about all the things that I've struggled with in my life, so the sensitive skin, the frequency urgency, the vulvodynia, the irritable bowel, the migraines. Thankfully, they only lasted for like a year in my 20s, thank God. The TMJ, the connection really is muscular and nerve, but mostly nerve. The muscle is a side effect of the sensitive nerve. It's a ripple effect. I'm not saying that the right way. I hope you understand what I'm trying to say. Mandy says, I'm finding it a nightmare to find a physical therapist who fits more than spa massage or orthopedic only. Mary, I have the Harvard database for medical care providers here on my computer, and I would be happy to look up your state and give you some recommendations. Let me open that file. There it is. So if you tell me what state you're in, I can, and/or city, maybe I can find one for you. Find a couple for you. Kimberly said, I've had a bad flare for over 2 weeks. I normally get bladder installations and dilations done, and they help. Nothing is helping me now. They have now put you on amitriptyline and Valium. I feel lost. I was just diagnosed as an IC patient about a year ago. I'm scheduled for a cysto on the 15th. I went 5 times for a bladder installation last week. Nothing is working. All right. So Kimberly, it begins with trying to understand what your subtype is, right? And if you come on over to our website, icnetwork.org, you can watch a video, the 5 subtypes of IC. But you know, the challenge here is you're just throwing therapies at it and you're not being specific enough. We have to really try to figure out what kind of flare you're having. Are you having a bladder wall flare or are you having a pelvic floor flare? Bladder wall flares happen if you eat or drink the wrong thing or if you're under a lot of stress. I mean, well, stress can trigger both, but you generally have pain as your bladder fills with urine that is relieved after you pee. So the fuller you get, the worse you feel. Ow, 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 ow. Oh my God, where's the bathroom? I need it right now. You sit on the toilet, you pee, and you're like, oh, thank God, I feel so much better. So if you have pain as your bladder fills, and that tells us your bladder wall's probably flaring. But if you have pain after you're done urinating, then we're going to be focusing more on your pelvic floor flare. So we have hour by hour rescue plans. If you come on over to our website and sign up for our free newsletter, you can download our 40-page flare management guide. I'd be more than happy to talk with you on the phone before your appointment. Maybe we can figure out over the phone what might be triggering, might have triggered this flare. So if it's a bladder wall flare, we're going to be, number one, diluting your urine, alkalinizing your urine, doing something that might numb your bladder wall, and then installations. If it's a pelvic flare, we're going to be working on relaxing muscles. So we're going to be doing heat. We're going to be doing pelvic floor work, stretches, relaxation, and muscle relaxants. The thing is they gave you both. They gave you the Valium to relax your muscles, and they gave you the amitriptyline, which might help calm your nerves down. But it's not clear to me, and it's just like it's not clear to you. Thank you, Elise. Thank you, Elise. Wow. You guys, you know who's in Facebook watching us right now? This is like one of the next heroes of the IC pelvic pain movement, Dr. Elise Day from Harvard Medical School. Holy moly, Elise, it's wonderful to see you. Thank you for dropping by. If you're still here, if you've left, that's okay too. But she says yes, like the princess and the pea. So Dr. Day, if you are up in the Northeast, would be a really viable option for you for a second opinion. She is also one of the co-editors of this fabulous book, Facing Pelvic Pain. Now listen, my friends, if you have no clue what's causing this for you, if let's just say you've done all the bladder therapies, nothing's working for you, even you've done pelvic floor therapies, and you just feel like you're not getting better, and there's a big question mark. What is this? This is the book you want to read, because they outline all of the other conditions that can mimic these symptoms, from pelvic congestion syndrome, which is what we talked about earlier, to musculoskeletal issues, to rheumatological issues, to neurological problems. I mean, like, if you just don't get it and your doctor just doesn't get it, you're just not responding at all. And you know what the American Urology Association says in their guidelines is, if you're not responding to therapy, if you're getting worse rather than better, stop. Let's take a step back here for a moment. Let's reconsider the diagnosis. Did we miss something? Could you have a fibroid tumor pushing on your bladder? Could you have endometriosis? Could you have a Tarlov cyst? Could you have pelvic congestion syndrome? Could you have a bad hip, a bad SI joint, a bad knee, something that's tweaking your pelvic floor? Could you have a tailbone that's healed out of position from an old injury? Right? I mean, you don't have to live in pain for the rest of your life. You have the right and responsibility to try to understand that pain a little bit more. And the challenge here is chronic pelvic pain is complex. It often, as Dr. Weiss says in his books, doctors like to play in their sandbox, right? Urologists like to stay in the urinary tract. Gynecologists like to stay in the reproductive tract. Gastroenterologists like to stay in the bowel. And they often don't look at interrelationships, or they're not trained, especially older doctors. They're not trained to look at how muscles can influence all three, or nerves can influence all three. And what we really need is a medical specialty on pelvic pain, where those doctors are trained in all of those things, right? So, challenge number one is you may be working with a local gynecologist or a local urologist who just is unaware of the other influences. They were trained 20 years ago that IC is an incurable bladder disease. They give you bladder therapies. If you're not responding to the bladder therapies, they're like, I don't know what to do with you, hon. Nothing's working for you. Maybe we'll take your bladder out. Right? Okay. Now the AUA says, okay, now stop for a moment. If the bladder therapies aren't working, take a step back, revisit the diagnosis. Is there another condition which could be causing this? Because your bladder can be victimized by something else happening. Again, like a broken tailbone, healed out of position, that's tweaking your muscles, keeping your muscles in tension, and you now have ischemia, right? So this book, if you're just baffled and people just don't understand it and you don't understand it, this is the book for you. And the cool thing about it is each chapter, number one, great pictures, like, you know, totally great pictures, easy to read. I mean, it's just wonderful. Absolutely wonderful. Like, I never have to worry about coming up with new content for the IC Network website, because all I have to do is just literally just pick a page and I'll be able to write an article on something on this page. So it's a great book. So anyway, thank you for coming in, hon. Nice to see you. Anne says, what is vulvodynia? Vulvodynia means that the vulva, you're having pain and discomfort in your vulva area. So the question is, what is your vulva? Your vulva goes from your clitoris down towards your rectum, and the entrance to your urethra, the entrance to your vagina, as well as your lips, the lips, your labia, your inner labia and your outer labia. When I had vulvodynia in my teens and 20s, it felt like somebody had rubbed sandpaper over my skin down there. Like I couldn't wear underwear. I couldn't use a menstrual pad. I was just, you know, messed up. And the doctors just kept saying, my wonderful Dr. John Renfrey, who is now passed away, lovely man. He was our gynecologist for all of them. His answer was, Jill, you're a redhead. You have the most sensitive skin in the world. But that didn't help. I mean, dozens and dozens and dozens of diflucan, because we all thought, and monostat, because we all thought it was yeast. It was never yeast. And this is one thing that Dr. Weiss does so well in this book, is my pain was concentrated, my vulvar pain was concentrated on my perineum, which is between the rectum and the vagina. And that's where the worst pain was. And he explains why. He explains why that is, because immediately above, immediately above the perineum is something called the perineal body. You see this? This is the perineal body. This is immediately just above the skin of your perineum. And do you see what that is? That's an attachment point for muscles. 4 distinct muscle groups pull on the perineal body. Thus, perineal pain is often a sign of one of those muscles being dysfunctional and or pelvic floor dysfunction, right? So in hindsight, I go back and think about those years I had that. I'm 100% sure it was related to tight muscles instead. So technically, you have to have had a vulvar pain for 3 months, and they're basically unable to figure out why you have vulvar pain. That's when you get the diagnosis of vulvodynia. It could be related to estrogen atrophy. It could be related to tight muscles. It could be related to several other things. In fact, we have an article on vulvodynia in our fall IC Optimist magazine that you'll be able to read. And just Google it. There are a couple. Vulvodynia Foundation is fabulous. The Vulvar Pain Foundation is fabulous. One of the self-help tips that's important for somebody with vulvodynia is you might notice that foods that are high in oxalates tend to irritate the nerves a little bit more. So foods like spinach, berries, chocolate, if you find that that irritates your skin a little bit more, then you want to back off on those. That was the Vulvar Pain Foundation. Kimberly says, my symptoms are UTI times 1,000. Kimberly, do you have a fever? Do you have burning in your urethra? Because you got to remember, the bladder only knows one language, frequency, urgency, pressure, pain. Everything feels like UTI. A bullet wound would feel like a UTI. Cancer would feel like UTI. Everything feels like UTI because you only have 2 nerves down there, the alpha afferent nerve, which gives you symptoms of frequency, urgency, and you got the C fiber, which gives you pain. So I know you feel like it's a UTI because we all felt like it was a UTI, but injury causes the exact same symptoms. Kimberly said, let's see, Ann says, is overactive bladder and IC similar? The answer is it's all about urgency. If you're running to the restroom urgently because you're in pain and you're trying to reduce pain, that classifies you as IC. If you're running to the restroom because you're afraid you're going to leak, that classifies you as overactive bladder. Elle, thank you so much for the 530 stars. That's very sweet. Thank you, thank you, thank you so much. Elle says, I also use the wand to release tension and do the stretches. I wish it helped. It takes time, hun. There's so much you can gain when you take the time to feel those muscles down there. It's like when I first started my own internal work, I didn't know what the hell I was doing. I mean, I was sticking it in. I was just randomly touching here and there and here and there. And I just was kind of pointless. I didn't know what I was doing. I honestly, for about a year, I just barely did it because I just didn't get it. And I finally got referred back to physical therapy, and I'm like with a physical therapist who I see now. And it's like, okay, how do I do this? How do I do this? I have no clue. I'm laying on my back. I'm using a wand. What do I do? And she kept saying, you follow the muscle. It's a J shape. And I'm like, what? It's a J? I'm laying on my back. There's no J shape. And she goes, just go home and think of a J. It's like a J shape. There's J on one side and a J on the other side. and so I did. I went home and I tried it. And I just I still really didn't quite get it. But then I got this book. And this book showed it to me. And it absolutely is a J shape. Let me go get my model, which is out in my living room. Hold on. Let me get my model. I'm using it. Sure. It's okay. I don't know if they're coming or not. All right. So let us ponder the pelvic floor for a moment. So hello, pelvis. This is your pelvis, right? It's the center and core of the human body. The human body is arranged in very logical ways. The bigger the bone, the more weight it's meant to carry. Thus, the biggest bones in your human body are, in fact, your hip bones. Why? Because it carries the weight of your torso. So concept number one is that the pelvis is at the center of the human body. It also deflects the stresses when you're running and walking. Those are all deflected right back up into your pelvic cavity. So that's important too. But now when you look inside, you have to understand that these muscles have a clear functional purpose. I mean, if you want to move your knee out to the side, you need these skeletal muscles in the pelvis, right? So not only is it supporting weight, but it's center to you being able to move your body. These muscles are also flat. You can see that they stay flat on the bone, right? When the muscles are tight, they lift off the bone. They kind of arc up, but they're supposed to be flat on the bone. So you can see this. You can see that they're flat on the bone. So here's the J shape. The J shape goes up like this. So on both sides, we have a J shape. So generally with pelvic floor physical therapy, they follow the length of the muscle and they're trying to get the muscle to flatten down. They're trying to calm it down so it'll flatten and go right back down onto the bone. Sometimes they'll go crossways. That's another way of kind of tricking that muscle to relax. And if you have a trigger point somewhere, they may push on that trigger point and to try to get that to release. I mean, if you ever have a muscle knot in your back, what do? You have a family member or friend push on it. When you push on it, it will release. It will usually release, or rub it, right? So that's what they do in the pelvic floor too. They will do that too. So, I mean, it's interesting. As I lay, when I'm laying down, right? So I'm laying down like this. So just pretend that I'm laying down. This is a very easy movement for me to make. Now that I know that that's the movement, and now that I know my body, I can tell the muscles are nice and relaxed on my left side. I can go far. And it's not with my finger, it's with a wand. And you can have your physical therapist teach you how to do this. Whoops. So this is the Easy Magic wand from IC Relief. This is my favorite wand by far. It's a Pyrex glass wand. I don't like the plastic ones because they can leave little pieces of plastic in your body, supposedly. I prefer the glass ones. These are really, really easy to clean. And this is absolutely the perfect shape. And so it's very easy, at least for me, to do the J. You see that? There's the J on both sides. Super, super easy. And it's, so I guess the point that I'm trying to make here is that when you take the time to learn your muscles and work with the muscles, it becomes very easy to feel when the muscles are getting messed up. And ultimately, in the end, it's your ability to recognize when your muscles are starting to get tight. Your ability to get in there and do something about it sooner rather than later is pretty important. So for me, and again for me, so here we put on the shallower muscles here, right? My pain right now is right here. It's hard as a rock on one side right here. And this is the side where I ruptured disc in my back. And so when I do my physical therapy, when I do this, I'm going the length of the muscle, but then I'm also trying to work on that little area where it's just really tight. And she just thinks that it's the ruptured nerve in my back that's irritated, that's causing that. So don't be afraid of doing this. I mean, in the end, the more comfortable you are working with your body and your muscles, the better. I hope I made that kind of clear. Jennifer, thank you so much for the 200 stars. Woo! I feel very special today. I so much appreciate that. Thank you for thinking of me and thinking of the IC network. Elle says, I use a wand to release tension and do stretches. I wish it helped. Again, so Elle, here's the thing. In this book, Dr. Weiss was fascinated by the patients that didn't respond to physical therapy. It's like you'd be in his clinic, he'd work the muscles, you'd walk out with fairly normal muscle tone, but a week later, a month later, 2 months later, you would have exactly the same trigger points and exactly the same tension in exactly the same spot. That really baffled him. It's like, wait, I worked on you. You were normal when you walk out of the clinic. Why are your muscles screwed up again? So he took a step back and went, okay, well, what puts long-term stress on muscles? Bones, joints. So he started looking at bones, joint. He also started looking at fascia to see what put stress on that muscle in that specific location. So it makes sense. I mean, if you got a bad hip and you're limping or something like that, then that's certainly that's gonna be an issue. Normally, your hips are meant to be level when you're moving, right? You're walking, right, like this. But if you're limping badly, like this, That could put some stress and torque on these muscles. Or if you have scoliosis, maybe you've got one hip higher than the other, or you have one leg longer than the other. That's going to put some funky tension on the muscles. So a bad hip kind of makes sense. A bad SI joint certainly makes sense. So here's your SI joint right here. The SI joint is where your hip connects to your sacrum. So if your SI joint is moving too much, the pelvic floor muscles in that area tend to get tight to try to stabilize that joint a little bit, SI dysfunction. So that makes sense. Even a bad knee, having a bad knee where you're just not walking correctly and you're limping again, that certainly is going to put extra stress and pressure on your pelvic floor. But here's the thing, the last piece of the puzzle for him turned out to be the feet. And it's the chapter on the feet that will blow your mind in this book. Because what he found is that for 95% of his patients who struggled with long-term pelvic floor tension, it was because they were not walking normally. They were not walking normally. They had shin splints, they had plantar fasciitis, they had they had Morton's toe, Morton's neuroma. There was an issue with how they were walking. And the diagram in this book that there's one diagram in this book that's just absolutely awesome. Let me grab that real quick. Okay. So I want you to look at this. Look at this diagram for a moment. Okay, so here's somebody who has an ankle that's rolling in. But let's look first at the normal leg, okay? The normal foot and the normal leg. You're going to see it goes pretty much straight up, and then through the bones, you end up, if I get a little bit closer, you can see here that the pelvic floor muscle on this side is normal. But now look at what happens when your ankle rolls inward. The first thing you notice is the angle of the bone. It's immediately directing your lower leg at an angle. It's not straight up, it's now at an angle. And that gets worse as it goes up. And if you look closely, you can see that the pelvic floor muscles on this side are stretched longer than on this side. And that's going to be a long-term chronic source of muscle tension in this muscle group. As long as this ankle's rolling in, this muscle group, this side of the pelvic floor is going to be tight and messed up. And now imagine what that does over time. Imagine the effect that that would have over time with your muscles. And so, hold on a sec. Let me see. Foot problems can alter body mechanics, leading to stresses in the lower extremities and the pelvis. Therefore, effective treatment of pelvic myofascial or pudendal nerve problems requires that foot abnormalities receive appropriate concurrent therapy. So the following progression of treatments can be used to reverse foot abnormalities associated with pelvic pain. Number one, stiffer, more supportive shoes generally improve overall foot functioning. In other words, get the hell out of the high heels. Number two, over-the-counter inserts. Number three, functional orthotics. I wear orthotics in my boots. And whatever else that podiatrist might need. So here's a case report. I'm going to read you two case reports. Case number one, it's a man with perineal and hip pain. So pain in the perineum by his rectum, along with hip pain. A 50-year-old man has been seeing me occasionally for over a 10-year period for intermittent perineal pain. I'd been treating his tight pelvic floor muscles and trigger points with internal manual therapy. Though he received great relief from these treatments, pain flares inevitably occurred. Frankly, I'd never completely understood the mechanics of his symptom flares until he came in one day complaining of hip pain while walking over hiking trails. This led me to question him further and ultimately put us on the right track. I asked if there were any other musculoskeletal problems that he had not thought to mention previously. He responded that he had always had pain at the base of his large toes, which he attributed to arthritis. But because he knew other family members who had the same problem, he never sought attention because he thought it was a congenital issue. I then examined his feet and found small bunions and moderate overpronation. And at that moment, the light went on. I found the origin of his hip pain that he experienced during hiking and also of the intermittent perineal pain. Pediatric treatment eliminated his pain flares. Okay, now let me do the second case study because this is even better. This is a 65-year-old woman with urgency, frequency, and urethral pain. A 65-year-old woman came to see me with a history of recurring urinary urgency and frequency and urethral pain without infection. Examination revealed tight hip rotator muscles with trigger points. I released the trigger points with internal manual therapy, to which she responded positively. However, she continued to have pain flares. While my treatments were effective in the short term, the results only endured for variable periods of time. At the time of her last visit, armed with new knowledge, I looked at her feet and I noted unusually high arches. When I asked her if she had experienced any potential side effects, she came out with Achilles tendonitis, knee surgery, and more recently hip pain when awakening and rising from a crouching position. And in my mind, I visualized a straight line of mechanical stresses. It began with a foot imbalance, which affected the Achilles tendon, then the knees, then the hips, and ultimately the pelvic floor. A visit to the podiatrist was the last stop on her healing journey, and it is unlikely she will require many, if any, additional treatments from me. 10 years ago, when I first saw this patient, the feet seemed too distant from the pelvis to be considered in the treatment plan. Experience has taught me otherwise. Case, let's do another case. Let's do 2 more cases because these are really, really interesting and important. And here, hold on a sec. I got to look at Facebook here. I always want to make sure you guys are okay over here on Facebook. Jennifer, thank you so much for those stars. Okay, hold on. Jennifer, 3 donations. Thank you so much. All right, let's do another one. A 31-year-old woman came to me complaining of vaginal pain during intercourse. The symptom was completely alleviated with manual therapy for tight pelvic floor muscles and trigger points of the internal hip rotators that I had noted upon examining her initially. However, the patient then began to notice vulvar pain when she exercised, which I surmised had been there all along, but had been masked by the predominating vaginal discomfort. Not infrequently, localized pain presents themselves in the order of magnitude. Only when the initial discomfort clears will the patient become aware of subsidiary distress. All right. When I re-examined this young woman, I found nothing in the vicinity of the pelvis that might be causing her vulvar discomfort. However, this time I scrutinized the lower extremities for clues to her, quote, new symptoms and found extremely high arches, which were no doubt the cause of previously noted hip rotator trigger points. I referred her to a podiatrist who fitted her with orthotics, and the vulvar pain disappeared completely. This was one of the cases that led me to realize the importance of a routine biomechanical assessment at the time of the intake examination. You know, our new book, IC 101, is not just a bladder disease, guys. We're trying to get you to look beyond the bladder right now. If you have a normal bladder, you're not responding to bladder therapies, let's take a look beyond the bladder. We got to look at other structures, see if anything else could be causing this. And it literally could, according to Dr. Weiss, be how you're walking. That would lead to long-term pelvic floor tension, which would lead to ischemia, which would lead to oxygen deprivation, potentially in the bladder and other tissues, which could eventually also start causing some of the bladder symptoms we associate with IC. Laura, thank you so much for the stars. Alyssa says, I finally saw a urogynecologist that diagnosed me with IC when I was 18. My regular doctor was putting me on so many antibiotics because they thought I just had a chronic UTIs. Diet was the number one thing that saved me, but also my flax heating pack is my best friend, and the supplement Bladder Ease saved me from flares. I was also diagnosed with pelvic floor dysfunction and have therapy. You are exactly, you're the prototypical IC patient or who was put on antibiotics that over years, just like I was, and completely ineffective. And the fact that modifying your diet started to show you, oh, whoa, Halloween. Oh, the spider's back. Oh God. I have this big giant spider. I have this big giant spider in my office. It's like this big. No. Oh, no. Oh, no, don't you dare come over here. Hold on. Ah, yuck. Go away. Go. Here. Hold on. Ah, crap. Okay. This little spider has been daunting me. He was here for our Thursday meeting too, or our Wednesday meeting too. It's hysterical. Stay over there. Okay. So Alyssa, so I'm really glad that you're doing better. The heating pad is relaxing your muscles. Heat really helped me too. The Bladder supplement is not, we have one challenge with the Bladder supplement, and that is that the quercetin comes from citrus bioflavonoids. So some patients have found Bladder Ease to be a little bit on the irritating side. Bladder Rest, the typical supplements, the Cysto Protect, the Bladder Builder, the Bladder Rest, the Cystoman do not use quercetin from citrus bioflavonoids. They use it from the Sephora plant. So pay attention to that a little bit. We just didn't see a lot of success with Bladder Ease, but if it's helping you, power to you, girl. Power to you. Everybody's different. Laura, thank you so much for the 500 stars. Wow. You guys are wonderful. You're absolutely wonderful. Jennifer says, thank you so much. Oh gosh, I totally forgot about the Zoom meeting. Totally forgot we could do Zoom. Let's see. Oh God. It's coming towards me again. I got to go get a glass. Hold on. Stay. They would be here around 4. An hour. I'm usually a master at catching spiders. I catch and release spiders all the time, but this little sucker is really fast. Dang it, where are you? Where did it go? Dang it. Oh well, okay. Well, I got my spider catcher. If I see it again, I'm going to try to catch it. Okay. There's my Halloween fright. All right, my friends. Well, listen, last call for questions. We've been doing this for about 2.5 hours. So anybody wants to go into Zoom, I'd be happy to go into Zoom and talk with you one-on-one or in a small group, your choice. Last call for questions. So in my office, what we're going to be doing this week is we're putting together our fall magazine, still working on the IC101 diet guide and the IC101 flare guide. Our new app, Bladder Tracker, is out. It's free. It's available in the iTunes store and the Google Play Store. It will allow you to track not only your urinary symptoms, it will allow you to track your diet. It will allow you to track your exercise, your stress, intimacy. It just allows you to monitor things over time, which is really, really useful. So we've got that out. Going to be doubling down in November on the International Pelvic Pain Society conference. I'm going to be summarizing that in our next magazine. We'll be announcing the IC Awareness Month poster and meme contest winners. The poster contest winner is Lynn, and her daughter is second place. And I don't remember the name of the third place. It's a tie for third place. Hopefully, I'll be announcing those tomorrow. What else? Tony says it's his holiday, the spider. It is. There he is. He's crawling at my lamp. There he is. Come here, you sucker. Come here. He's a jumping spider. Ah, okay. Oh, darn it. I can't catch him. He's not on a flat surface. Yeah. All right. Any other questions? Any other questions? If not, I'd say we're done. And I'm gonna get. I wish my nephew were here with his kids. I would show you their cartoon. I mean their costumes, but they're not gonna be here for another 45 minutes or so. Rhonda says, thank you for the tip on congestion syndrome. I just hope my doctor knows. You need to see an interventional radiologist as a person who would make the ultimate diagnosis and treatment. Pelvic congestion syndrome is actually pretty easy to treat. You can actually see it sometimes on a sonogram because you can measure the size of the blood vessels. And generally, if a blood vessel is 5 millimeters or bigger, that's considered an abnormal size. And so I will be doing another article on that because it was fabulous. So anyway, Anne says, if you use the wand, will your frequency lessen? Well, if you use the wand, hopefully you're restoring good muscle tone, which is then restoring some blood supply, which would then tweak your bladder wall less potentially and tweak those nerves a little bit less potentially. So over time, it should help improve some of your other symptoms, but I wouldn't expect an immediate effect. Although, like I said, I had really. Oh, Debbie says I'm late, but I'll watch. Yeah, you're going to be part of the spider journals. We've been chasing a spider all day in my office. So, Anne, all I can say is that I have this one area that's just super tight, and it's just really hard, and it's painful when you touch it at first. And it takes me about 3 to 4 minutes of using my wand to get it to relax and drop. And if I let it build over time, like I didn't do my internal work for about 5 days, and by the end of the 5 days, it was bad. And I was really having a lot of rectal pain and just perineal pain. And just one session, but I knew exactly what I was doing and where I was working. The pain was gone the next day. I mean, so it was fairly, and I haven't had any pain yet today. So now it's 2 days so far. We're working with these muscles is working. Where did it go? I'm glad I sleep at the other end of the house. I would hate to have the spider on my bed. All right, guys. I think we're done. I think we have come to our natural conclusion. May you go have fun with your trick-or-treaters. Go enjoy your white chocolate Halloween candy. That's going to work just fine. I really hope you guys have a really fun night tonight. I fully intend to enjoy my night tonight as well. And happy Halloween. And in 3 weeks, we're going to do Thanksgiving, 3 to 4 weeks. And so now we're in the joyful part of the year. And I hope that you have a lot of joy in your life every day. What Sam says, hi, is Elmeron any good? Should I try natural therapies? This thing is really bad. Okay, so Sam, I don't know if you're a guy or a girl. It would be helpful for me to know that if you wouldn't mind. So if you look at, so let's just assume that you've got interstitial cystitis, bladder wall driven. Okay, so your IC was caused by some sort of chemical irritation to the bladder, or chemotherapy or ketamine or something like that, where your bladder wall got really traumatized. Elmeron is the equivalent of a chemical Band-Aid. It's a coating. And I have a picture here. Let's see here. So this, okay, so you're a guy. Okay, so we're gonna mix this up, but let me finish this first, and then I want to talk to you about a couple of different things. So this is actually one of the old Elmeron materials, educational materials. And what we have is a three-dimensional picture of the bladder wall. So we've got the superficial mucosal barrier, gag layer. This is that nice thick coating of mucus that protects the cells underneath. So when you have a nice thick coating of mucus, it makes it hard for your urine to reach your urothelial cells and or your nerves down here, right? But if you've suffered some sort of injury to your bladder wall, look what happens. This urine now gets where it's not supposed to be, where it starts to irritate these tissues, irritate the nerves, et cetera, et cetera. So what Elmeron does is it's a bit of a chemical coating, the equivalent of a chemical Band-Aid, okay? Our challenge, of course, there are a couple of challenges with Elmeron. I mean, it was approved back in 1996. I was a support group leader when it was approved. It's a very, so 3 points to consider. Point number one is, if you swallowed a Band-Aid, would you expect it to come out the other end of Band-Aid? And the answer is no, we have digestion. We have digestion. And so one of the biggest challenges with Elmeron is something called its bioavailability, and that is how much Elmeron actually arrives in the bladder to be helpful. And what the company's own study showed that 92 to 93% of Elmeron is destroyed by digestion. And so only 5%, and some doctors, I had one doctor say he thought it was 3 to 4% earlier this year. So functionally, very little of the Elmeron arrives in your bladder to be useful. And that's why you have to take a lot of Elmeron over time for it to be beneficial. But that then brings up our second point. And our second point is long-term use of Elmeron has now been linked to retinal disease, pigmentary maculopathy. And when I say long term, the new warning label, on the Elmeron says it's about the 3-year mark that the greatest risk for retinal disease is present. However, they report that patients who have taken it less than 3 years have shown changes in their vision. Our own Elmeron study showed patients reporting changes in their vision in the first year. So Elmeron has fallen out of favor as an oral therapy because of this new, really profound eye issue. Yeah, however, if they're using it as an instillation where they're putting it directly in your bladder and you're not swallowing it, that is a better way to use Elmeron because number one, 100% of the medication arrives in your bladder to be therapeutic, right? And its ability to be absorbed into your bloodstream to cause other issues is much less. Elmeron does have quite a few side effects, blood thinning, stomach upset, hair loss, things like that. It's a fairly rigorous medication to take orally, but using it as a bladder instillation is much better. Now, you say here they offered you a bladder instillation. If you look at the treatment guidelines for IC published by the American Urology Association, there are 6 steps of treatment. And the steps are arranged with respect to the risk of adverse event. They don't want you to do the dangerous stuff until you do the easy stuff. So in step one is the basic foundation of self-care. It's water intake, it's diet modification, because seriously, if you're pouring acid on the wound every day, you cannot expect the wound to heal, right? So diet modification is important. Your job is to create an environment that will support healing in your bladder. And the American Urology Association talks about muscle relaxation, and they suggest using the supplements, some of the supplements like Bladder Builder, Bladder Rest, Cystoprotect, Cystomen. Somebody mentioned Bladder Ease earlier, Allopath. They specifically encourage the use of supplements in step one because they have far fewer side effects than the treatments in step two. So what's in step two? Step two are some of the oral medications like Elmeron, like an antihistamine hydroxyzine, or amitriptyline. There are bladder installations like an Elmeron installation, a heparin installation, a rescue installation, or pelvic floor physical therapy. That's step 2. Step 3 is Hunter lesion therapy and hydrodistension. Step 4 is neuromodulation and Botox. Step 5 is cyclosporine, etc. So you're a long way from that stuff. You're really right now at step 1. And so if you're newly diagnosed with IC, I mean, I think the very first thing you've got to think about is, are you eating or drinking something which is irritating the hell out of your bladder? Because today's modern diet is really aggressive, and your bladder was never designed for energy drinks, monster drinks all day, or coffee all day, or diet soda all day. Your bladder, is vulnerable. And if you're not drinking water and you're pouring acid on it over and over and over again, that's just going to take a toll, and eventually the bladder is going to start to react. So we really want to look at your diet. Let's see if there's anything in your diet that is triggering bladder irritation. That's concept number 1. And then I think the other thing, when I work with a lot of guys, and I always want to take time, a little bit of extra time with guys. Now, ladies, do not be offended by that. You have to understand that women have far more support opportunities than men do. And some of the men that I work with, they are really isolated. And it's very, very important that they have an opportunity to talk with somebody. And so I always want to make sure that the men that I'm working with, just as the women I'm working with, are getting the support that they need. Sam says, yes, I followed your vids and changed my diet this week. Awesome. And are you noticing any difference at all, Sam, now that you've changed your diet? What were you eating or drinking that was forbidden? Like, were you drinking a lot of coffee or soda, something like that? I want to plant another seed for you, Sam. And this statement, I got some people who really disagree with me for saying this, but all I'm going to do is I'm going to explain my perspective working with men over the years, especially in the last 5 or 10 years, now that we know the questions we want to ask. 90% of the guys that I work with, when we go back in time, we can find a trauma of some type. And just, I work with guys pretty much every day. Okay, so you say, hold on, it stings less and less frequent. Okay, good. And you were drinking a lot of tea. God forbid it be green tea. Green tea is agony. Green tea is so acidic. It is so irritating to a tender bladder. So, but any of the teas, and then also spicy food, okay, that makes sense. But what I want you to do, here, my dad wants me to take his picture in the middle of a stream. Hold on. Dad, you want to come over and say hi? So you guys, this is Jack Osborne, my dad. He'll be 99 in 11 days. All right. Okay, why don't you shut that door there, and let me just take one more picture. Okay, so Sam, I want you to go back to when your symptoms began. The first time, can you just shut that? Was there any event, had you fallen, riding a bicycle, motorcycle, taking a long car ride, anything at all like that? No, all the way. Were there any events that you associate with the onset of your symptoms? Rhonda says, wow, he looks great, Jill, 99. There you go. There you go. Good picture.
Have a good time.
Thank you. Thank you, Dad. They're going to be here around 4, okay? Let me tell you, he's a handful. He's a handful. Like, we're evacuating from a fire, and he's not supposed to drive, and he insists on driving his car and gets lost in the middle of a fire. Yeah. All righty. I love him, though. That's why I'm here. I love my parents. It's going to help him. So again, Sam, can you think of a trauma? Was there any sort of event that you associate with the onset of your symptoms? You just proved my freaking point, Sam. Sam goes, I was punched in the testicles by mistake, and you had a lot of stress in the same week, and that was 12 months ago. There you go, my friend. There you go. So, you know, understand that pelvic trauma is complex. So number one, we have to consider the fact that could your muscles have also sustained an injury, or was the punch to your testicles so strong that the pain was so intense that your muscles just kind of locked down over time, right? Are you struggling with pain now? What are your symptoms now? Abby says, hi, Jill. Any new treatment for subtype 2 patients? I've tried it all. Still get yes. I was going through a lot of new research and a new, is that it? There's a new therapy called High Deal D. High Deal D. The combination of high DLD and hyaluronic acid for protecting and restoring the urothelium. That's something new that's starting. They're also working on immunomodulation, a molecular solution for treating patients with severe bladder pain syndrome. That's coming out of Sweden. A couple of studies on cyclosporine. That cyclosporine, yet again, is a real game changer. Some doctors like Ken Peters are calling it kind of a miracle drug for those patients who are not responding to other therapies, but they very clearly have a bladder wall issue and a bladder wall inflammation. And, so the cyclosporine is, the reason why it's a step 5 treatment option is it comes with a lot of risk of side effects, but there's a pretty significant group of patients who are using cyclosporine who are doing remarkably well. And one of them is a friend of mine who's a member on Facebook. And I was just talking with her again. And honey, if you're watching, I hope you're doing okay. She just lost her mom. So if I won't say who she is, but sending good thoughts your way, okay? So she was probably one of the most severe IC patients. I've known her for years. She's a personal friend, 20 plus years. Her pain, way worse than mine, way worse than mine. And yet she was still teaching. She would do installations at school. She used pain medicine when she needed to. And it's like a remarkable woman, very, very strong. Very strong. Bladder therapies just simply didn't work for her. And finally, they tried cyclosporine, and it's completely changed her life. Like, she doesn't need pain medicine anymore. She doesn't need to do bladder installations anymore. It's stunning how her life has turned around with cyclosporine. But she does have one of the side effects of cyclosporine use, which is high blood pressure. So, but it is a real game changer. Okay, so Sam, I've got varicocele because of the trauma. You're having an operation to sort it out. The IC is pressure in the lower half of my stomach. Bladder extends out so much like I'm pregnant. I haven't heard a lot of guys say that. So, it's going to be really interesting to see how you do once they fix the varicocele. Do we have a Facebook group? We do, but I personally don't monitor it anymore. I'm really busy. We have a forum on our website, but we don't use Facebook we only use Facebook to do these meetings. I have a couple of staffers who try to watch out here and there, but we're drawn very, very thin. So anyway, so not only can muscles affect the bladder and nerves affect the bladder, but so can blood supply, so can veins and arteries. If there's a problem with a vein or an artery, and you're getting pelvic congestion syndrome, which can happen in men and women, where you've got veins now that are stretched out, what happens is they start collecting a lot of blood at the end of the day. So you start the day feeling pretty good, but by the end of the day, you feel like you're carrying a big, heavy bowling ball around in your pelvis. Or you might notice that standing up and walking has become more painful. So concept number one, given the fact that you have a varicocele, is I wonder if there's more to it than that. I don't know, hon. I don't know if Dr. Day is still in here. Probably not. She'd be the right person to ask that question to. And then the other half too is, that sometimes that icy belly is a result of inflammation. The pressure is the interesting thing. Yeah, Amber, it is. Yeah. I think you're going to have to follow the basics for IC for a while. Follow the diet. I mean, clearly you were hurt. You were hurt fairly badly. And you know what? This book, hold on a sec. This is the book for you, my friend. We really want to try to understand the context of that injury, of you being hit in the testicles. This is the book to get, because there's a whole chapter on what male urological problems can lead to pelvic pain, what can be done to treat it. Yeah, dude, you got to get this. You got to get this book. And it's free on Kindle Unlimited. It is Facing Pelvic Pain. And it's produced by Mass Gen. The editors are Harvard doctors. I wonder if this might be helpful. Let's see, chronic testicular pain. Doesn't talk about the swelling that you're getting. I don't know. I would be happy, Sam. I'd be happy to talk with you a little bit more and see if we can find any other resources for you. If you want to give me a phone call this week, that would be fine. Our phone number is at the top of our website, 1-800-928-7496. I'm off on Mondays because I work today. So Tuesday through Friday would be, I'd love to talk with you. If you'd like to talk, maybe we can dig a little bit deeper into some of the research. I haven't had a lot of guys say they have a lot of belly swelling. I mean, it's not coming to me right now, but who knows? I might just be having a brain moment. But I'd be happy to look into it a little bit more and see if we can find anything. Rhonda says, can you repeat those, Jill? The treatments? I was on cyclosporine for lupus. I have a minor blood disease for me. I had to get off. God bless her that she's okay, but this drug has a lot of side effects. Yeah, it does. You want me to repeat the 6 steps of treatment? You can find them right on our website. In fact, there's a whole pull down menu that shows all the 6 steps of treatment. So you can go in each step and read what we have to say about that. Okay. Elizabeth says, I'm looking for a bladder supplement. I might be allergic to shellfish. I noticed all the supplements on your site have chondroitin from shellfish. Do you have another recommendation? Yeah, unfortunately, they all do. Chondroitin only comes from, it might be the glucosamine, actually. Chondroitin can come from chicken, it can come from shark fin, and it can come from cow trachea. So the chondroitin in Cistro Protec and in Bladder Builder and Bladder Rest all comes from chicken. But it's the other, I think it's the glucosamine that comes from the shellfish. Gosh, really, your options here, hold on. Let me just grab this for a moment. Let me just look at these real quick. Hold on. So bladder rest has not formulated with wheat, gluten, soy, milk, egg, fish, shellfish, or tree nuts. There you go. That's probably going to be the one. Or you can go over to the aloe path, which is just organic anthraquinone-free aloe combined with PEA, which might help calm some nerves down. Or maybe you could even just go to the PEA, palmitoethanolamide. How do I spell high DD? Hold on. Let's see. Thank you. Hold on. Let me go back. Any new treatment for subtype 2? Oh, you mean the new one? Yeah, it's probably not available yet. I haven't even written an article on it yet. This is just all the latest research. This came out in September. So hyaluronic acid. Hyaluronic acid has been used as a bladder installation for many, many years in Canada and Europe. It's under the name of Cystastat. And then chondroitin has also been used as a bladder installation. That's known as Uracyst. And what was funny is that the two companies competed. You know, they wanted to be the top dog. And the reality is neither one of them really were the top dog. And then somebody put the two together and combined hyaluronic acid and chondroitin as a bladder installation. And the name of that is Ialuril, Ialuril, Ialuril. That has very, very good research results for calming and soothing and coating the bladder. Ialuril, Ialuril. Let me put this on Facebook too. Ialuril. Nope, hold on. Got a typo. Ialuril. So you can find the bladder rest on our website. The manufacturer is Natural Approach Nutrition. So this would be ideal for you. This is kind of the formula for people who are super, super sensitive. That was the intent when we were talking about treatment, and they were working with me and Dr. Peters and a couple of other people. I just kept saying, people are sensitive. You need a formula for people who are really, 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 really sensitive. And so this is the formulation that's kind of the simplest and the cleanest for people who tend to be more sensitive to stuff. So bladder rest. And when you try something like this, it's very important that like one capsule, if you're sensitive, just take one capsule with food. You never take it on an empty stomach, especially before you go to bed, and wait 24 hours and see how you do. I mean, that's the approach for anybody who's sensitive to stuff anyway. I mean, you're probably already doing that. You never take a full dose the first day. You got to make sure your body tolerates it well, because we all have weird sensitivities, right? Rhonda, I will do it when I get it written up. I don't have it written up yet. I mean, like literally, I just read about it yesterday. And you're right. Ialuril is not available in the US. However, your doctor can request it from a Canadian pharmacy if you wanted to try it. There are patients in the United States using Ialuril. You just have to buy it from Canada, one of the pharmacies in Canada or one of the pharmacies in Europe. All right, guys. Well, listen, I think it's time to call it. I'm going to go put out my candy for Halloween. And I hope you all have a wonderful evening. Let's just enjoy the spirit of the day. And I hope that some children will help you laugh if you can. Get out and walk a little bit with the trick-or-treaters. Wear your mask, of course. And just let the joy of the day lift your spirit and fill your spirit. So here's your homework for 15 minutes a day. I need you to do something that will soothe your spirit. comfort you. You deserve comfort. You're working hard. You've been scared. You've been traumatized. Let's do something that will nurture you a little bit, whether it is going and sitting outside in the sun, listening to some music, watching a church service, whatever works for you, do it. For 15 minutes a day, I need you to do something for your bladder, your pelvic floor. Yes, that means you got to go lay on your living room floor and do your exercises, whatever they may be, and or prepare an IC-friendly meal. For 15 minutes a day, I need you to improve your knowledge. Come on, little articles, little things every day. I mean, come to our website, read a blog, go to the ICA website, read a blog. Or if you get a book like this, you can do a chapter a day, or you can do a chapter a week. But you got to get your knowledge level up here. I want you to be able to walk into a doctor's office and be able to talk to them like I talk to them. If you walk in without the knowledge, that you're going to be talked down to and you won't know to ask the right questions. You need to remember your power pose. What's the power pose? Power pose. If you're not feeling confident when you're walking into an appointment, one of the best things you can do is, so you're waiting out into the waiting room, stand up, pretend you're Wonder Woman, just sit like this. And you know what happens is that produces testosterone. You're changing your position, produces some testosterone. And that helps you walk in with a bit more confidence and power. You are an equal participant to your medical care. You are more, because if you don't do the stuff at home and you're relying on the doctor to fix you over and over and over again, that's not going to get you where you need to be. There's this whole foundation of self-help that we know can improve the quality of life, your quality of life, and improve your health. If you were addicted to soda, it's time to stop it. Your bladder is not designed for soda. It's not. It's screaming in pain. Help me, help me. Stop pouring the freaking soda in it. Soda's not healthy. Let's get back to the basics. How about water, some chamomile herbal tea, some peppermint herbal tea, right? Right? If you're living with stress and your stress level is off the charts and you've got anxiety disorder, understand that intensifies pain. We have to learn some skills so that you're not living in fight or flight. That is huge here. That's where all the new research for all these chronic overlapping pain conditions is focusing on, is central nervous system. How do we get the central nervous system out of fight or flight? It's called mind-body medicine. It works beautifully. And you know what? Let's end that meeting with this. This is what we're going to do. We're going to end this meeting with my favorite mind-body medicine technique. It's called I Spy. Okay? So for anybody right now who you're just freaked out, man, you're in pain, you're frustrated, you're angry, we can fix this in 3 minutes. I'm going to show you exactly how to do it. It's with good sensory information. Remember that your brain on any given day is monitoring your senses. There's not a lot of cognition happening. Your brain is paying attention to, what do you smell? Is it a fire, or is it something you like a stew cooking? What do you hear? Is it a siren, or is it somebody singing? What are you touching? Is it hot and burning you, or is it cold? Your brain is focusing on sensory information, and it's the sensory information that ultimately puts you in fight or flight. So it will say, your brain's going, okay, here's a new smell. I don't know what this is. And it pays attention to your history, and it pays attention to your context. If you're anxious and you smell smoke, your brain's going, oh my God, your life is at stake. There's a fire. And it's going to put you into fight or flight. So we'll do one I Spy, and then we'll be done for the day. Okay. So I want you to pick something that in your room to look at. So I've got a bunch of butterflies and fairies hanging right over my head. So just pick something to look at. Now take a deep breath in, deep breath out. Okay. What can you hear? Can you hear anything right now? Do you hear anything besides my voice? Do you hear TV? Do you hear traffic? I hear TV. Do you hear somebody talking? Just focus on that for a moment. There's no threat to it. Okay, nice slow deep breath in, deep breath out. What do you taste right now? Can you taste anything? I'm drinking my herbal coffee latte. It's good. No acid, caffeine free. Okay, what do you taste? Anything. Okay, take a nice slow deep breath in, deep breath out. What do you smell? Can you smell anything right now? This is where having a little room spray, that's not chemical, obviously, is really, really good. Aromatherapy. What do you smell? Anything? I can smell my latte. Okay, deep breath in, deep breath out. Now I want you to take your hand and I want you to rub it up and down your leg. Are you wearing jeans? Are you sitting on a chair with upholstery? Rub your hand up and down. Okay, it's no problem there. Now let's take a nice slow deep breath in, deep breath out. And your brain's going, I don't know why she's rubbing her leg, but it's okay. There's no problem. All right, now comes the fun part. And I challenge you to do this with everybody in your family, especially children who are struggling with anxiety. If you could look at anything that would put a smile on your face, what would it be? If you could look at anything that would put a smile on your face, what would it be? For me, let's just say trick-or-treaters, little kids. So just think about that for a moment. Now let's take a nice slow deep breath in, deep breath out. If you could hear anything that would put a smile on your face, what would that be? Would it be children laughing coming up the walkway? Would it be music? Don Denver, Kenny Loggins, your favorite? Think about that for a moment. Okay, let's take a nice slow deep breath in, deep breath out. If you could smell something that would put a smile on your face, what would that be? What would that be? Piece of cake for me. Hot apple pie, hot cinnamon rolls, which I made this morning. So live there for a moment with your favorite smell. Nice slow deep breath in, deep breath out. If you could taste something that would put a smile on your face, what would that be? What would that be? For me, piece of cake, hot apple pie, or hot cinnamon roll, my two favorite things in the world. So think about it. Visualize what you're eating, your favorite thing in the world. Oh my God, it tastes so good. Deep breath in, deep breath out. What could you touch that would put a smile on your face? What could you touch that would put a smile on your face? And Brian says strawberry cheesecake. Yep. Okay, what could you touch? Your lover, your child, your cat, your dog, your horse, a pet? What could you touch that would put a smile on your face? I know what some of you are thinking right now. That's okay. You can think that. Okay, now let's take a nice slow deep breath in and a deep breath out. Okay, how do you feel? We've just turned off fight or flight. When you give the brain sensory information in a good context, you turn off the sympathetic nervous system, you turn off fight or flight, you've turned off the amygdala, and now we are living the way our brain is functioning the way it's meant to function. The parasympathetic nervous system is taking over. How do you feel? There's no anxiety, right? It's gone because you've turned off the anxiety center. Sensory information in a good context. There's a lot of other ways of doing it. This is what mind-body medicine is all about. And it's just so useful. It's so important. Positivity too, and having good anxiety management skills are important too. Anyway, I've covered that before. We got to go, guys. Come on, Halloween. I'll see y'all later. Y'all have a good evening. I'll see you on Thursday. See ya. Bye-bye.